definitely going to be a 2-day series of just incredible health innovation combined with what is absolute top tech innovation as well over the course of the next coming 2 days for what is the 7th annual Growth and Resilience Dialogue of the Eastern Caribbean Central Bank. Good morning again. So we'll roll right into it. I will invite Mr. Samora Sharabin to give what is the opening prayer, and I ask you all to stand for this, please. Thank you.
Operators, our partner institutions, all those partnering with us, the technical teams who are ensuring that things flow as smoothly as possible. We pray for all those who will be attending in person. We pray for safe travels for them. Lord, we pray for all the countries and organizations that are being represented here over the next 2 days. We pray for meaningful contributions, active participation. We pray that what happens over the next 2 days will spark the growth and foster the resilience needed in our countries and in our region. We make this prayer through Christ our Lord. Amen.
Thank you, Mr. Sharabin. Please allow me to acknowledge you can have a seat. Thank you. Be seated. Please allow me to acknowledge the presence of the Honorable Prime Minister of St. Kitts and Nevis, Dr. Terence Drew, the members of the ECCB Monetary Council, the cabinet members and the governments of the governments of the ECCB member countries, the members of opposition of parliament, Mr. Timothy N.J. Antoine, the Governor of the Eastern Caribbean Central Bank and Chairman of the Board, Dr. Valda Henry, the Deputy Governor of the Eastern Caribbean Central Bank, Ms. Tracy Polias, the Chief Director of Policy of the Eastern Caribbean Central Bank, the members of the Eastern Caribbean Central Bank Board of Directors, the members of the Diplomatic Corps, the permanent secretaries and the other government officials of the ECCB member countries, the host of the 7th Growth and Resilience Dialogue, myself, the presenters and panelists of the 7th Growth and Resilience Dialogue, media practitioners of the Eastern Caribbean Central Bank member countries, management of the Eastern Caribbean Central Bank, staff of the Eastern Caribbean Central Bank, and our viewing audience, both live and our virtual audience as well in terms of the different platforms, Zoom, ECCB Connects, and of course via Facebook and YouTube. So thank you all for joining us today. So I should announce some house matters just by starting out by informing you rather that we will in fact be having a draw where the lucky participants, those who would have registered online, will be awarded what is going to be a grand prize of the equivalent of $2,700 EC or 1,000 US dollars to be able to have what is going to be a health check at any facility of their choice in their country. Yeah? And this is something that will be drawn on day 2, in other words, tomorrow. However, the winner must be in attendance at the time of the draw. Okay? So we encourage you all to stay engaged with us so that you may in fact be this lucky winner. We will now move into what is going to be our first speech of the day. And for this, we are going to invite the Honorable Prime Minister, Dr. Terence M. Drew, Prime Minister of St. Kitts and Nevis, and the Minister for Finance, Office of the Prime Minister, Ministry of National Security, Social Security, Citizen by Investment Program, and the Ministry of Health. Dr. Drew, thank you.
Good morning to all. Morning. Good morning. Let me start by saying it is indeed a privilege for me to be here. I think that fora like these are the types of fora that we need to really advance our country and to advance our people. And interestingly enough, as I look at what this year's theme is, I think I used to practice some months ago in this area. So maybe, apart from being the Prime Minister and Minister of Health, I think I have some professional credence to speak to this topic. And so I want to really congratulate the Central Bank for its initiative and being the leader that it is, not only here in St. Kitts and Nevis, but in the region, really to help us to set ablaze the paths that are necessary to ensure that we continue our growth and development. Let me recognize the governor of the bank. Of course, Madam Moderator, allow me to adopt the rest of the protocol, but allow me also to recognize the governor of our bank, Honorable Antoine, and to also recognize the representative from the World Bank, Lilia, who is here with her team. Welcome to St. Kitts and Nevis. But I also want to welcome, I see the member of the Assembly from Nevis, Honorable Janice, who is here with us as well, and any other person who is here from the assemblies, and those of you who are from the clergy and so forth. But I really want to welcome all of you to this pivotal session that we have here. Let me apologize early that I have another session to go to, as this is our diplomatic week, and we have about 50 plus ambassadors from around the world who have come here to St. Kitts and Nevis, and so I'll be interacting with them. But I hope to return to this session so that I can further listen to you. Do more listening than talking, but add where I can add. So in St. Kitts and Nevis and the rest of the Eastern Caribbean, the COVID-19 pandemic had an unprecedented impact on our health systems, our economies, and the lives and livelihoods of our people. COVID-19 influenced supply chain and really affected us in multiple ways that we have not resolved as yet. It revealed gaps in the health systems, which must be plugged to ensure resilience, preparedness, and readiness to respond to the next public health threat, which could be occurring now, next week, or next month. Currently, the public health threats to the ECCU include the norovirus gastroenteritis, which has been traced to outbreaks in our source markets, influenza with new and emerging strains which have the potential to cause future outbreaks. Influenza, as you know, that's seasonal flu. Vector-borne diseases like dengue, meaning it is transmitted by the bite of a mosquito, chikungunya and Zika, cholera, which is impacting Haiti at this time, antimicrobial resistance, and natural disasters, including flooding, hurricanes, earthquakes, and volcanic eruptions. The ECCU is challenged by many public health incidents and emergencies. The theme and focus of this year's Growth and Resilience Dialogue is appropriate and timely. I am particularly looking forward to the outcomes of the first plenary session, where I want to participate in hearing the policy recommendations for the two priority areas. One, preparedness and response to health emergencies. 2, enhancement of the cohesion between doctors, dentists, veterinarians, and environmental health practitioners to adopt the One Health initiative to effectively combat the antimicrobial resistance challenge and to ensure stewardship of antibiotic usage. The second plenary session hopes to highlight the value of traditional, folk, or complementary medicine in today's world. A sizable proportion of our patients use traditional medicines and some form of traditional knowledge in health as a form of self-care, or more specifically, as a personal primary health care strategy. We know this. We drink hot soap down, right? And the cattle tongue bush. And this came from hundreds of years of observation. And this should not be taken lightly. And that is why I'm happy that this is actually a part of it. Our healthcare providers tend to be more oriented into modern medicine and should also be sensitized to the role of traditional medicine because the typical patient often has a different worldview to that of nurses and doctors. How many times we are told as doctors, well, I stopped at the blood pressure pill, I'm taking the bush. It is a common thing in St. Kitts and Nevis. I support the call for more research in this area to inform how traditional medicine can effectively interface with modern medicine. During the pandemic, we witnessed firsthand the benefits of the collaboration of both forms of medicinal practices, modern and traditional, to combat the symptoms of COVID-19. For example, the blend of turmeric, ginger, and lemon juice for its anti-inflammatory effect and to help boost the immune system. We also used sunlight and a plethora of other types of herbs, which of course would have contained a lot of vitamins to help to combat the infection that many of us suffered. Research has underscored the therapeutic benefits of cannabinoids. Cannabinoids is a fancy name for cannabis, marijuana, ganja, as we call it in this sub-region. And we therefore welcome the third plenary session. We anticipate regional data on the uses of cannabis, along with hearing about the best practices in establishing a medicinal cannabis industry. I can say that St. Vincent in the OECS has already shipped medicinal cannabis to Germany, and that St. Vincent has a lab that is already approved by the EU system, where once their cannabis is tested to be safe in St. Vincent, it is allowed to be shipped into the EU market. So there's already some advancement in our sub-region. In St. Kitts and Nevis, we intend to develop such an industry and hope to partner with our colleagues in this regard. So as we strengthen our health systems in preparation for future public health threats, we must embrace innovative technologies to ensure efficiency and efficacy in healthcare delivery. Digitization of the operations of the Ministry of Health is a priority of this government. And so we look forward to the exposition schedule for day number 2. Digital technology could help make unsustainable healthcare systems more efficient, improve the interaction between patients and medical staff, and offer more affordable, quicker, and more effective treatments for diseases. A few examples of technologies that enhance medical facilities and healthcare delivery are artificial intelligence. Very interesting. A study was done with Google. And if you're not a medical practitioner, don't do it. But if you were to introduce as much signs and symptoms into Google search, the diagnosis normally pops up in the 5 options that Google gives you. Quite interesting. AI, we know, is already being used in medical schools as we look at flowcharts that medical students and doctors can use to reach a diagnosis that is more dependable. So AI is fundamental in medical practice today. Machine learning is also important, and virtual care and telemedicine. Why is this important? Because our region is small. I don't think we have 1 million people in the OECS member countries. Yet, our demand for quality healthcare is extremely high. And our expectations as members of this sub-region, these expectations are also high. And so, telemedicine or virtual care can offer access to high quality healthcare without leaving the region. Just to put things in perspective, already we are going to partner with the University of Hamburg, Germany Medical Center to assist us in virtual medicine or telemedicine with respect to reading our MRIs, X-rays, ultrasounds, and delivering other type of knowledge transfer opportunities. This is very powerful. AI technology can be used to diagnose illnesses and provide specialized remedies. Internationally, the pharmaceutical industry is using machine learning to find novel medication candidates instead of time-consuming and expensive traditional way of searching through chemical libraries. Virtual care became an important practice during COVID-19 pandemic, and it is allowed medical professionals to remotely interact with their patients. This is very interesting in terms of using the technology to develop vaccines. There is a virus that normally affects children called the rotavirus. And AI was actually used to develop a vaccine to deal with rotavirus. And so studies that used to take sometimes decades can be narrowed down by 1/10 of the time. And so they use this system to really develop a vaccine for this type of virus, and the vaccine proved to be effective. And so AI is impacting medicine significantly in positive ways, and that is why it has to be a part of our tool that we would use to deal with improving our healthcare delivery. These are critical future healthcare considerations for our region as we work toward fortifying our healthcare systems and to transform our nations to sustainable island states. And if you look at the word here, it says resilience. One word, but sustainable, which is quite important as well. And that, I think, we need to not only apply it to other industries, but it needs to be applied also in the healthcare sector. Very critical. So our current goal is to address our anxieties about the future head-on, approach technologies with an open mind, and gain as much knowledge as we can to position ourselves for the changing world. As Prime Minister and Minister of Health, I, with my team, have prioritized investments in healthcare, investment in essential infrastructure and equipment upgrades, most vital being the construction of a new smart hospital. Why is this critical? With climate change, we are expecting stronger hurricanes. As it stands, most of the infrastructure were not built to withstand the stronger hurricanes that we might expect. And we cannot afford to have a hospital that is not resilient, understanding the threat that we have been told so much about, especially over the last decade. We are also looking at the purchase of critical equipment like MRI machines, EEG machines to test the brain, modern ultrasounds and so forth, and the advancement in general of health sector institutional enhancement projects are forecast on our agenda, a part of which includes the digitization of our healthcare system. The digitization is important because it helps with efficiency. Why is it important to do it? How many times people go to the doctor and the doctor says, so what medication are you taking? Well, doc, I'm taking a small white tablet. How does that help the doctor? People really don't know the names of their medication. That can lead to medical errors. Not only medical errors, but that can also use to excessive spending and incur significant costs. Why? If you were to show up to a doctor and you said, well, I got some white tablet last week from the hospital. The doctor does not know what you had. you don't know, and the doctor has no way of accessing your health record from the hospital to know. And so the doctor prescribes a next set of medication for you that you go and buy. And so you are doubling up. And it seems like one patient, but when you multiply that across, you quickly come to recognize that that is an expense that you could have avoided. The other area that you have waste, well, I went to the doctor the other day and I had an ultrasound done. What is the result of the ultrasound? Well, doc, I can't remember. They said this is something over here on this side and something over there. That's a new doctor who wants that information. So what does the doctor do? Well, let's get a new ultrasound. Again, excessive spending. Had the doctor had access to an electronic health record, that doctor could have gone into the system and could see your medical health record and be informed and make the appropriate decision. And therefore, it is important just to announce today that Cable has won the bid to connect all of the health institutions of St. Kitts and Nevis by fiber optic, or with fiber optic. And by the end of the year, we should have our electronic health record system in place. And so we are going to use the technology right here in St. Kitts and Nevis to create what we call a resilient system, but apart from that, a sustainable, affordable health system as well, using the technology. So since assuming office, we have already purchased the MRI machine, new surgical machine, ophthalmology equipment, laboratory equipment, new theater equipment. We have sourced new dialysis machines, and we have also sought to bring in new specialists as well. We are currently in the midst of an extensive consultative process and moving swiftly towards the operationalization of a national health insurance scheme which will offer tremendous financial benefits to our people. That again is part of building a resilient and sustainable system. A lot of people across our sub-region do not have health insurance. And as a result of that, you know what the outcome is. Earlier death, lack of treatment that they could have had otherwise. And those things not only affect health of individuals and communities, but they affect our economies as well because of lost years of productivity. And the economists, they know better than me that that would have a tremendous negative impact on the growth of any economy. COVID-19 has taught us that enough well-trained human resources for health is required to respond to any public health threat. However, we need to grasp the latest technologies to enhance its offering to attract other persons into the profession. I want to end by saying and introduce something new to the discussion, as I would not be here. But permit me to add this dimension. Presently in the ECCU, there is a lack of medical centers of excellence. There's hardly any country, island, that has centers of excellence. When many of our people have to access specialized care, on many occasions they have to travel abroad where care is extremely expensive. Those who lack the financial resources or don't have appropriate health insurance go without care or substandard care. I have seen patients who might have had a chance to live, but they die because of lack of access. We can therefore consider, and I hope that this gets to the other heads, and I intend to bring this also at the CARICOM level as its chief spokesperson for health, we can consider establishing a center of excellence on each island or territory that each of us can have access to. Break it down into simple terms. St. Kitts and Nevis can have a center of excellence for cardiac diseases, heart disease. St. Vincent might be able to have one for gastrointestinal issues. Antigua might be able to have one for neurological diseases. What I'm simply saying here, that it calls for collaboration and a shared vision that we need to provide for our people in this sub-region top-class healthcare. But we are too small for each of us to carry that burden. And if we share the burden, then there are greater possibilities that within this sub-region, we can have centers of excellence that can serve all of our people. Barring that, it's going to be extremely difficult for each island to provide quality health care in a significant number of areas for our citizens. I, as the Minister of Health, have quickly recognized that our budgets do not allow us to carry that burden. Our population sizes do not allow us to implement these centers of excellence all on the same island or in the same territory. And so just like how we have a common currency and we would have taught the world how to do it, I think we have an opportunity to expand that depth of collaboration and understanding the importance of sharing our burdens to ensure that at the end of the day, our people would have access to good quality health care. And let me wrap up by saying, of course, I feel privileged to have been given this opportunity. And once again, I want to congratulate the ECCB for being the leaders that they are in ensuring that today's activity that we are having today and tomorrow would be had, so that at the end, it would lead us down a path to create healthcare systems that are resilient and sustainable, so our people can have the privilege of excellent healthcare. Thank you very much.
Thank you, Honorable Prime Minister. Please allow me to acknowledge as well the online presence of the Honorable Prime Minister and Council Member of Antigua and Barbuda, the Honorable Gaston Brown. Also, too, we would like to acknowledge the presence online as well of Dr. Didicus, His Excellency Dr. Didicus Jules, the Director General of the OECS Commission, as well as the presence of Ms. Lilia Burunchik, Country Director for the Caribbean region, Latin America, and the Caribbean region of the World Bank. Thank you all. So we would now move into our next presentation, which is that of the Governor of the Eastern Caribbean Central Bank, Mr. Timothy N.J. Antoine. Governor Antoine, thank you.
Thank you very much, Madam Master of Ceremonies, Dr. Tate. And for those of you who don't know, our moderator is, in fact, a medical doctor and oncologist, I believe.
Thank you.
And we are grateful for her presence. So, aren't we blessed? We had a doctor to give us our keynote address. By the way, you just heard the keynote address. You know that. Dr. Drew, thank you so much, Prime Minister. The fact that you prioritize this, even as you have to head off to diplomatic week, is an expression of your commitment to healthcare in this region, in St. Kitts and Nevis and this region. And I'm really happy that you spoke before me, or I'm coming after you, because my work has been made so much easier. So here's the breaking news. I will not give you my full statement. You should applaud, you should be happy. I will circulate my statement, but I will just point to a few issues. But let me adopt the protocol, but do recognize Prime Minister Drew, another Prime Minister Brown, and any other member of our Monetary Council who's joining us online, or members of Parliament, and any other leaders of opposition who are joining us online, and of course, our social partners, labor, business, youth, civil society, churches, and anyone else in the social partnership. Thank you so much for your presence today. On the last occasion when I addressed you, so I want to formally welcome you to our 7th edition Last year when I addressed you on the 6th edition, I did so in a fully virtual format. And so we're very pleased on this occasion, our 7th edition, that we have a hybrid model where some of us are in person and others are joining us online. And I think we are clear, going forward, the hybrid model is going to be the model. That said, we hope, as our air connectivity situation improves in our region, more of you will be able to join us on our campus, and that we'll have an even bigger room of partners physically present at the central bank. But we fully expect, next year and going forward, more people here, but also many joining online, because that, essentially, that model gives us the best chance for maximum participation, and that is key. At the outset, I want to acknowledge our partners in this enterprise: the OECS Commission, the World Bank Group, the University of the West Indies, who have worked with us over the years, and also our planning committee, led by Ms. Sybil Welch, Senior Product Specialist at the Central Bank. Put your hands together now for our planning committee. The theme for this year, an appropriate, and I should insert, affordable and sustainable model for healthcare in the ECCU OECS, Agile Infrastructure, Traditional Medicine and Medical Cannabis. And I must say, when I was offered this theme, I found it a mouthful. And even as I say it, it is still a mouthful. And I wonder whether we had bitten off more than we can chew. But having seen the panel, having heard the keynote from Prime Minister Drew this morning, I think we'll be all right. Won't you say? I think we'll be in good shape by the end of this dialogue. So I'm very grateful to all of our panelists who have readily consented to be part of this dialogue and to share in your expertise, experience, and expertise on this theme. I want to offer 3 key messages, and I'm going to list them right at the top because I'm not going to try to cover them all. First of all, Prime Minister covered them, and secondly, he is a practitioner, and I feel I will be wasting your time to try to repeat some of those things. First, the criticality of healthcare, primary healthcare, the criticality of primary healthcare. One of the key lessons of the pandemic is the criticality of primary healthcare. And it really is inspired by the old adage, prevention is better than cure. If you think of the more than 1,000 victims of COVID-19 in the ECCU, many of them suffered from pre-existing conditions, comorbidities, which are essentially our non-communicable diseases. And in our region, you know, and I want to repeat, it's a frightening number, but we have to be clear, because it's a silent epidemic. Almost 8 in 10 deaths in our region are attributable to non-communicable diseases: diabetes, hypertension, heart disease, cancer, and so on. Just think about that. And if you go around the currency union and you look, there is a high number of amputees in this region, principally because of diabetes. And black people, African descent people, have the highest propensity, it appears from the data, for suffering from diabetes. Now, there are economic and socioeconomic reasons for that, but the point is that we are seeing it. So if you think of what that does for a household, if you think that what does for a community, if you think about what that does for an economy and a society, where people in their prime are cut off because of these diseases, you would understand we have to do far more to attack the scourge that is non-communicable diseases in this region. And so I'm grateful for what Prime Minister Drew had to offer on this, because I think with your leadership and the collective action of others, we will be able to tackle this scourge. And so I look forward. As a region, we must invest in primary health care to save lives and livelihoods. Indeed, that is productive for our families, for our public finances, our foreign reserves, and our economy. And I want to be very clear. In investing in primary health care, we have to invest in diagnostic facilities to support early detection and treatment, but we must also, of necessity, and this is important, take personal responsibility for our health. That includes healthy eating, active lifestyles, and a commitment, a culture of checkups, medical checkups. Too often, we resist doing these medical checks, and I'm happy that the prize is a medical check. And some of you would say, give me the money in my hand. Well, your health is more important than money at this point. Because too often we defer and we delay. And many times when we do it, it's only because our women, our wives, our partners, our mothers insist that we go to the doctor and get checked. And far too often, when we finally arrive at the doctor's door, stage 1, stage 2, stage 3, stage 4, and then we are going around with a bowl in our hand trying to raise money for a stage 4 situation. It breaks my heart. It breaks my heart to see this happen over and over again in our member countries. And therefore, the culture of taking personal responsibility also has to be spoken of, even as our governments invest in primary health care. Second is we must leverage digital, indigenous and digital technologies. Prime Minister spoke on this. I don't want to add anything else except to say, if you missed our anniversary lecture in Antigua and Barbuda last month on the silver economy and the use of traditional medicines, check it out. How can you check it out? Go to our YouTube page, ECCB Connects. And by the way, if you're looking for something, Facebook, ECCB Connects. If you're looking for YouTube, ECCB Connects. If you want to check out our weekly podcast, it's called ECCB Connects. Well, I'm going somewhere with this. What is the bottom line? ECCB Connects. Should I give me a quiz on that and see if you could get the answer? So I will say no more on that. Finally, effective collaboration and collective action. This is so key. If we want to attain an optimal and sustainable model for healthcare in our region, we have to have effective collaboration and collective action. And again, Prime Minister Drew spoke to some of those when he spoke about centers of excellence across the region. We have a very good model in the OECS with the joint procurement of pharmaceuticals, where we estimate that we save about 50% on the cost by coming together and doing joint procurement. We are advocating this morning for an expansion of that model from more pharmaceuticals. And we also believe we have to use it to also procure expensive equipment. So some of the MRI and some of these things, I know the question will come up, well, funding and so on. We could work that out. We could work that out, just as we've worked out the model with OECS, and we have all of our member countries have accounts at ECCB, and during the pandemic, we actually put money into those accounts for our member countries to help them procure certain vaccines and certain medical equipment, PPE, and so on. I think we could do better and more on that model. It already is a working model that we need to expand. The area of health insurance, Prime Minister Drew spoke to that. It is a key pillar in a global health system. But it is very expensive, and we need to collaborate on that. And we have said, as a region, that there are a number of things we need to do there, including certification, standards, and so on, and the leveraging of our social security systems. We have to fund them, I want to be clear. But what we ought not to do is to put on top of our already difficult situation an expensive administrative machinery to do national health insurance. And we could look around, there are examples, Bermuda, BVI, and others, that we can draw lessons from and tailor for our needs. Another area of collaboration is research. And I want to recognize what the University of the West Indies has been doing in respect of medical cannabis, and to say we need to do more of that with our indigenous medicines, with our herbs, not just medical cannabis, but a number of our herbs that could bring to bear on our health care. That is an area for partnership. Laboratories, medical research institutions, doctors, pharmacies, communities, coming together for the safe use of indigenous medicines, whether in their natural state or otherwise. And then Prime Minister Drew spoke to what already has been going on with the export of medical cannabis in St. Vincent and Grenadines. St. Kitts has announced an industry as well, and plans and so on. I will say we still have to work with the US, where at the federal level it is still a prohibited substance. But certainly in the EU and in Canada and some of those places, there are opportunities. And we have to work together so that the financial system can play its role in this emerging industry. So let me conclude, because I said I would be brief. At the launch of our 40th anniversary celebration in January of this year, I call for a big push and challenge us to reflect on the question, what will it take to double the size of our economies over the next decade? What will it take to double the size of our GDP? St. Kitts and Nevis, it's 3 billion EC. If you go across the currency union, it's 21 billion. So how could we get from 3 to 6 or from 21 to 42 over, say, the next decade? That's a question that we will continue to visit throughout this year and going forward, because we have to answer it. But what I will say is that key to doing that big push is our health. Because at the end of the day, resilience begins with personal resilience, our health. And human capital is at the core. And health is the key to maintain our human capital. And by the way, I always say about resilience. What is resilience? It is our capacity to withstand shocks, absorb shocks, and bounce forward. Not back, forward. Because every crisis, every shock must have a legacy that allows us to be better than we were before the pandemic, better than we were before the hurricane, better than we were before the global financial crisis. That's a key part of how we build resilience in this region and transform this region. And ultimately, as we say in our vision, we don't just want to strive, we want to thrive. And that starts with the health of our people. And so I conclude with my often repeated statement. As a region, we cannot change our history. And we cannot change our geography. But collectively, we can elevate our development trajectory through innovation and collective action. Let's make the 2 days count. Thank you. God bless you all.
Thank you, Governor Antoine. I have a suspicion that Governor's phone will be ringing off the hook anytime from now, as he would have promised the region that we can work it out. Yeah? So we look forward to that, Governor. Thank you for your commitment. We would now invite our next featured speaker.
Just before, we want to allow the Prime Minister to exit at this time, and to wish him well with his next assignment and diplomatic week. Thank you, Prime Minister.
Thank you, Prime Minister. We would now invite His Excellency Dr. Didicus Jules, the Director General of the OECS Commission. Dr. Jules.
With us from Brown, distinguished members of the ECCB Monetary Council, the Bank Director for the Caribbean, Ms. Lilia Boronchik, Ministers of Government of the OECS and leaders of the opposition, Governor Antoine, Senior Management and staff of the ECCB, Senior Management of the OECS Commission, members of the Diplomatic Corps, representatives of government, the private sector, labor, and civil society. Following the decision of the ECCB Monetary Council at its 86th meeting held on the 21st of October 2016, the first growth dialogue was held on the 1st of March 2017 under the theme, Working Together to Achieve Higher and More Inclusive Growth in the ECCU. That forum provided a unique opportunity for civil and social partners to dialogue with the ECCB Monetary Council on matters of growth in the currency union. Ever since then, the Growth and Resilience Dialogue has been held and has provided an opportunity to stimulate thinking and discussion on issues important for promoting the region's sustainable economic development. And the ideas and recommendations made have helped both the ECCB and the OECS Commission to enrich our mandates. The deepening of regional integration within the Eastern Caribbean was the impulse that led to the formation of the OECS in 1981. By mandate of the treaty, the OECS Commission has taken the lead in these initiatives in the area of health by creating and implementing various programs throughout member states' health systems. Regional responses to HIV and TB, as well as was referred to by Governor Antoine, the pooled procurement of pharmaceuticals and medical supplies for health systems, access and cost savings have been outstanding achievements in this domain. And in fact, to Governor Antoine's appeal, we have in fact extended the reach of the pool procurement, not just to equipment and laboratory supplies, etc., but to all equipment and material required by governments, whether in education and construction, whatever can be, wherever we can benefit from savings and efficiencies from pool procurement, we will undertake this. In more recent times, following the 2007 Port of Spain Declaration, regional collaboration has focused on dealing with chronic conditions, including high blood pressure, diabetes, heart disease, and cancer, given the illness, death, and economic impact of these non-communicable diseases. Most recently, following global outbreaks of Ebola, Zika, and chikungunya, the commitment to health and health resilience was renewed in the OECS with the 41st Declaration on Solidarity in Health, the establishment of the Health Unit, and the adoption and implementation of an OECS 2017 to 2030 Regional Health Agenda. In many ways, these outbreaks turned out to be useful preparatory situations for the COVID-19 pandemic when it paralyzed the world, because the agile systems that were put in place for the management of infectious disease outbreaks enabled us to respond effectively. It is very important to note that despite its deleterious effects on globally, the mortality rates from COVID-19 in the OECS were among the lowest rates in the world. At the same time, the COVID-19 pandemic revealed areas of vulnerability and obstacles that must be addressed if we are to achieve the objective of a higher quality of life for the people of the OECS. It punctuated the importance of achieving economies of scale in the provision of specialized health services. And I heard very clearly Prime Minister Drew's call for centers of excellence in health. In fact, in education, for the longest while, we have promoted the idea of centers of excellence in education. It highlighted our vulnerabilities to environmental and economic shocks by dramatizing the nexus between disease control, travel and trade, and economic dependence on imports. We continue to be confronted by issues such as pediatric obesity, mental illness, the recurrence of diseases such as Zika and dengue, and several variants of COVID. Our environmental fragility is further exacerbated by climate change and natural disasters like hurricanes, earthquakes, tsunamis, and volcanic eruptions. The theme for this year's Resilience Forum, OECS Declaration on Health, an appropriate and sustainable model for healthcare in the ECCU OECS, and Agile Infrastructure, Traditional Medicine and Medicinal Cannabis, clearly defines and supports our efforts as SIDS to ensure healthcare for all. The OECS member states have been working to develop a suitable and sustainable model of healthcare for the region. By signing the OECS Declaration on Health in 2017, member nations reaffirmed their commitment to regional solidarity in healthcare. The OECS Declaration on Health elaborates several commitments to the development and support of collaborative initiatives via current or new structures aimed at realizing health for all. This includes the sharing of specialized services and human resources in the health sector, broadening of the pool for purchasing of a wider range of medical supplies and services, and the creation and adoption of standard legal and policy frameworks for the health sector. In fact, just recently, we're looking at standardized legislation and processes for registration of health professionals across the OECS. The inclusion of traditional medicine and medicinal cannabis signals the recognition of the long overlooked opportunities for incorporating not just cannabis, but traditional and indigenous medical practices and products in the care economy. As long overdue as this may be, let's have no illusions of the magnitude of the challenges that we face in incorporating these in an appropriate and sustainable model of healthcare in the OECS. Many developed countries and big pharma have a long technological lead in the research and bioengineering of traditional herbs and plants from all over the third world and are well ahead of us in the appropriation of our bioresources. In fact, in many cases, we have lost the opportunity to have the intellectual property rights on these bioresources secured. Some of our governments, notably the government of St. Vincent and the Grenadines, as referenced by Prime Minister Drew this morning, are well advanced in addressing these challenges. For example, critically addressing the location of cannabis in the narcotic sector and ensuring that precautions are taken that trade in medicinal cannabis does not suffer from prescription as trade in narcotics. And in ensuring that once again, our people are not marginalized and disadvantaged in this burgeoning global market. The theme of this edition of the Growth and Resilience Forum is timely, as it reminds us of the importance of healthy citizens for economic growth and as a key element of human capital alongside education. And nothing else brought this home more emphatically than the pandemic in reminding us of the importance of strong health systems and how this is directly related to economic sustainability. Fora like this, which bring together stakeholders from the public, the private and civic sectors to explore innovative solutions to the problems that we face, are increasingly necessary in these volatile, uncertain, and complex times. Many thanks to the ECCB for partnering on such an important event, and we look forward to an exciting and successful dialogue. And thank you.
Thank you, Your Excellency, Dr. Didicus Jules, Director General of the OECS Commission. We'll move right along and we will invite Ms. Lilia Burunchik, the Country Director for the Caribbean region of Latin America and the Caribbean region of the World Bank.
Good morning. Dear Governor Antoine, dear Director General of the OECS Commission, Dr. Jules, all protocols observed, dear guests, dear colleagues. It is a great honor to be here today and to make my opening remarks, although it's very difficult. I wish I was as eloquent as the previous speakers, and they've actually covered already a lot. It's really an honor and a privilege for the World Bank to co-host this event and partner with such a great regional organization as the Eastern Caribbean Central Bank. So thank you, Governor, for inviting us to co-host this event together with you. And thank you for choosing such an important topic for this growth dialogue this year. An appropriate and sustainable model for healthcare in the Eastern Caribbean. Developing such a model is not easy. And actually many countries in the world are indeed struggling to find it. Doing it for the Eastern Caribbean is even more difficult given the particularities of the region. However, with careful planning and innovation, we believe it is possible to create a model that meets the healthcare needs of the island's residents while remaining economically viable and environmentally sustainable. And as the governor already mentioned, and I hope everybody here believes that we can be successful in this regard. Often the expectations from the World Bank are that we know everything. And yeah, we do know a lot what's going on in the world, but we definitely don't know everything. And we also want to listen and to learn from this event and work with you together to develop new solutions and to come up with a solution that will be viable for the Caribbean. But here are a few things that we've learned throughout the world. First, and they were actually already mentioned by the previous speakers, so that's great. First is we need to focus on preventive and primary care, including to reduce the growing burden on non-communicable diseases. By the way, during the spring meetings, which took place just 2 weeks ago in Washington, many of the leaders of the Caribbean countries who were at the spring meetings did mention the heavy burden on the economies of the Caribbean of non-communicable diseases. So this is really an issue that needs to be addressed. The next one, second, and it's related, is develop strong public health systems. Public health measures such as disease surveillance, vaccination programs, and environmental health initiatives are critical for preventing and controlling existing and emerging infectious diseases. Third, it's to ensure access to healthcare for all citizens, which is called universal healthcare coverage. Access to healthcare should be a fundamental right for all citizens, regardless of their ability to pay. And universal health coverage can be achieved through a combination of public and private financing mechanisms with appropriate mechanisms to protect against the very high out-of-pocket payments, which we see sometimes. Fourth is to improve the efficiency of health financing within available fiscal space. And this means not necessarily spending more, but spending better, spending more efficiently. Fifth is collaborate regionally with the neighboring islands. Small islands often have limited resources, including healthcare providers and medical equipment, and can't specialize in everything. So collaborating with neighboring islands can help pool resources and improve access to specialized medical care. And additionally, sharing best practices and learning from one another can help improve the quality of care provided to OECS residents. Last but not least, and it was already mentioned extensively today, is the use of technology, much greater use of technology. And COVID has taught us to utilize internet and technology for a variety of purposes. What we have seen around the world is that actually telemedicine is a great way to provide healthcare services to remote areas, including small islands. Telemedicine uses technologies such as remote monitoring devices to connect patients with healthcare providers. It's actually amazing how much AI, artificial intelligence, can do. You know that artificial intelligence today reads better the X-rays and CT scans than humans. So the use of technology is something that can significantly aid the healthcare and improvement of quality of care for the patients in the Caribbean. So by implementing all these strategies, a sustainable healthcare model can be created for small islands that meets the healthcare needs of the population while remaining economically viable and environmentally sustainable. And I really look forward to the discussions today and tomorrow to see how we can arrive at a model that can work better for the citizens of the Caribbean. Thank you.
So we thank our distinguished presenters, as they would have definitely given us much to think about. I think the keynote here would have been the combination of what is the importance of partnership as well as that of prevention in terms of us being able to move towards or create what is an appropriate and sustainable model for healthcare in the ECCU. We will head straight into what would be our first panel for today. Before doing so, however, we would like to take care of some in-house matters. We will be inviting questions. However, we will ask that all questions be reserved towards what would be the end of all of the presenters having presented on the particular panels. The in-house audience, we would ask you to indicate by a simple show of raising your hand. And once you would have been identified, then you would be ushered to what would be a corresponding microphone to be able to pose your question or your comment to be able to contribute to today's event. Those who are in attendance online, you may present your question at any time, be it through the Zoom, be it through the ECCB Connects, be it through the Facebook. You will be able to send your questions at any time. However, likewise, we will be addressing those questions at the appropriate time. So we encourage you all to start preparing towards that segment. Our first panel discussion for today, which is an optimal model for the ECCU OECS healthcare infrastructure. Our moderator will be none other than Dr. Aman Quadri, who is the Chief Strategy Officer of the AMSYS Group. Dr. Aman.
Good morning, everyone. How are you?
Good morning, Dr. Aman. Thank you for joining us. Dr. Aman will be joined by Richie Etwaru, the Chair and Chief Creative Officer of Mobius USA, as well as Michael Dersham, the founder and CEO of MAPE, Ms. Odessa M. Ellie David, consultant data scientist at Capsire Inc., and Dr. Pilar Ramon Pardo, regional advisor of the Pan American Health Organization. Dr. Aman Quadri, PT, DPT, CERT, MDT, currently serves as a consultant in several technology verticals, including health tech, fintech, and future tech. He also serves as the Chief Strategy Officer at the AMSYS Group, where he helps across a conglomerate of over 14 companies. He has spent over 2 decades combining technology and healthcare, and has built a solid foundation around the empowerment of others and believes that technology can build the gap between financial services and healthcare. Michael Dersham, also known as Dersh, is a seasoned business development entrepreneur who has assisted multiple ventures and attracted millions of dollars of capital. He has an outstanding track record in strategic business planning and development, capital and financial sourcing, multidisciplinary problem solving, and technology development. He also has a strong technology transfer background, covering from government and university research to the private sector commercialization. Michael holds a Bachelor of Arts in Economics from Dixon College and an MBA. Richie Etwaru is a champion for innovation and co-founder of Mobius, a company that delivers frictionless technology. As Chair and Chief Creative Officer, he designs and delivers a new global sector of technology that redefines what is meant to connect. Richie has served as COO for technology at a large financial services company, a divisional CIO at a large investment bank, and head of innovation at a billion-dollar software company. He has sat on multiple startup advisory boards and has been quoted in news outlets such as NPR, Forbes, and Wired. Odessa Ellie David is a graduate of the University of Arkansas and holds a bachelor's degree in computer science and international studies. She has a master's degree in information systems and is currently a consultant who develops analytics solutions and provides technical support for energy companies in the USA and Canada. And by no means least, Ms. Pilar Ramon Pardo, Dr. Pilar Ramon Pardo, MD, PhD, coordinates the special program on antimicrobial resistance at the Pan American Health Organization, the WHO Regional Office for the Americas. After training as a specialist in internal medicine, she obtained her PhD from the Complutense University of Madrid with a thesis in antimicrobial resistance in Latin America. During the last 20 years, she has worked in prevention and control of infectious diseases in different regions or different countries throughout Africa, Asia, and the Americas. We now invite Dr. Aman Quadri to lead this first panel. Thank you.
Well, thank you. It's great to be here with all of you. One of the things that I wanted to set some rules for us, each one of these presenters is going to be doing a presentation for about 10 minutes or less, and then we're going to go into a series of questions. I want you to start thinking about the types of things that, that inspire you from these conversations. Think about those questions, be ready to ask them, and we're going to try to get to as many as possible. One of the reasons I was drawn to this resilience dialogue was the fact that many of the things that are discussed today and tomorrow are things that are affecting not only the region, but also globally, right? And so we want to start having these conversations and be able to work with ourselves. In the last 5 years, I've worked in things like smart patient rooms, track and trace technology for medical cannabis, digitization of health records, all the things that we're talking about. And so I think you're going to get a lot of these things mentioned today as well. And so we're going to just dive right in. So first one is Mr. Ritchie. He's going to be talking about innovations in healthcare with us with a short presentation. And then we'll pause for a second, and then we'll get Dersh up and running, and then we'll just go down the line. But really start thinking about the questions that you want, and let's have an open and fun dialogue today. Richie, you're up.
Thanks. Good morning, everyone. So I live in the U.S. and I was born in Ghana, and I've been living in the U.S. for 30 years. And I've traveled to the West Indies extensively and was just at the Visionary Summit in Jamaica. And so the reason why I was drawn to this is being someone that is from the Caribbean, so to speak, and has worked all across the world, I'm very excited to be able to work in the region that I was born in. And so this could not be more exciting for me. I know we're running a little bit late, so I'm gonna cut my presentation a little bit short here, and I'm looking forward to the Q&A. But I want to start by making one observation. I've worked with healthcare companies and healthcare transformations in the US, in Canada, in Asia, in Singapore, in South America, most recently in NEOM, in Saudi Arabia, which is the city that's being built from the ground up without any blueprints. And the thing that stood out to me on the remarks this morning is how good the language is on the speakers that came before us, the topics, the words that are being used. Because as you go through healthcare transformation, whether it's as a company or a country, the most important thing is to get the words right, to really understand the issues and to frame them in the context that they're in. And from the Prime Minister all the way through, I think I'm very excited because the Caribbean has the words right. It's the right words, it's the right topics, it's the right emphasis. And I think that's phase one of being able to get to a sustainable place. I'm going to focus on a couple of words here. Some of them are going to be obviously repeats of things that have been said before, but I'm going to shorten my presentation, as I mentioned, and really just focus in on a couple of things. So we heard already about prevention, and healthcare is moving from a cure-based experience to a prevention-based experience. And I think it's easy to kind of say this, but it's really hard to do. And it's hard to do because it has to do with people's belief in doing something when they actually don't need it. So prevention is something that has to happen way before you actually need an intervention. And across the board, whether it's from early prescriptions or how you educate patients or how providers talk about prevention versus cure, or how pharma focuses on prevention medicines and the economic model of prevention medicines as opposed to the economic model of cure-based systems, or how payers incentivize prevention actions, or what policies can be put in place for prevention to become a core issue, I think that if you're starting from the ground or you're starting from halfway and you're looking to modernize healthcare to be sustainable and resilient, prevention has to be a part of the conversation across the entire supply chain. And the difficulty there, to me, is education. I've seen many prevention programs start and they die very quickly because, let's face it, prevention is something that starts before you actually get sick. And so there's a fair amount of education and convincing that has to happen. It almost has to become a part of the cultural substrate of the society for prevention to be able to work. So we've heard the conversation about prevention before. I'm happy to have questions about it and take, pull examples from where I've seen it work or where I have not seen it work. But if I could leave this audience with one thing, it's that it is something that is very hard to do because it's cultural. It requires broad education of a society. It requires parents to talk to their children about prevention. It's that early that we have to engage in order to move to a prevention-based society. So getting the words right here, I'll move to the second topic. Healthcare is moving from an individual experience to an ecosystem involvement. And I think this is, again, across the entire supply chain. As we look at some of the examples of what we would consider to be modern healthcare systems, whether it's Norway or Singapore, most of us have this kind of, I'm going to go to the doctor. I have this one doctor that I go to, and that's the doctor that I'm going to engage with. And sometimes it's because it's the only doctor that you can reach. It's the doctor that you trust, or there's not anybody else to talk to. What I'm seeing in modern systems is that there's no longer this dependence on my relationship with one provider, but an ecosystem of providers. And that requires that you have the health information exchange that's in place so that these providers could talk to each other. That requires that you have the technology infrastructure in place. So if someone lives in a remote region and they only have access to one doctor physically, they may have access to more people electronically. That ecosystem, the benefit of that ecosystem is you're now having more people that can look at a patient from different vantage points and to be able to remove inefficiencies and implement policies and recommendations that can actually get faster to solutions. So this one-to-one is actually moving to a one-to-many, and in some cases, a many-to-many, where there's an entire care team that's working with a cohort of patients at the same time. I'm introducing these words so that we can start to think about what are the North Stars of what good healthcare looks like as we think about how we rebuild it in the Caribbean. Third, healthcare is moving from blockbuster solutions to personalization. This is one of those bleeding edge concepts of personalized medicine. If you think about medicine today, it's a lot of blockbuster solutions where you've got a particular thing that works for a cohort of people in a particular study, and then everybody else gets that same pill. Well, there's so much information now, so much digital monitoring that can happen, so much insights that can be gathered about a patient where you could start to differentiate what's different from one patient versus another and whether that patient needs the exact pill or 75% of that pill or 20% of that pill. So personalization is starting to become something that I'm seeing, really get adopted in the modern society. And this is where you get, access to the edge cases, right? Blockbuster medicine will work in one or two standard deviations of the bell curve, but when it doesn't work out on the edges, it's personalization that's needed. And that personalization comes from either deeper engagement with the patient to understand more about them, or more involvement from other healthcare providers to be able to see what is special about this patient that makes them tick as opposed to everybody else. Fourth, and then second to last, in the modern systems, healthcare is moving from an episodic thing where I only engage with healthcare when I need it, to something that's a continual engagement in education. And this theme is ringing through across the modern societies where continual engagement in education, whether it's public service agreements, whether it's the type of things that are taught in schools, in high schools and in colleges, whether it's the fabric of family and culture, this is a part of what is going to help the systems that are being built today go from this kind of wait until you have a problem and then pay the expensive price to fix it, as opposed to trying to start to deal with that problem early on so that it's not expensive. And then my last, which is the obvious, and this has been mentioned today from the Prime Minister onwards, is moving from a physical experience to a digital experience. I'll be presenting tomorrow on AI and technology and the new digital experience that can facilitate better forms of telemedicine, et cetera. But any system that's being built today, when you think about the word infrastructure, infrastructure is something that is no longer just the buildings that we have and the people that we have. It's the technology, it's the software, it's the integration, it's the AI, it's the access to data, it's the digital monitoring, it's the smart devices. The modern systems today that are being built digital first. And that's because this is a way where you can actually start to scale the economics and the unit economics of a system by being able to take advantage of the newer versions of technology that are giving you better performance, as opposed to relying on analog systems, which are very hard to replace. So I'll stop my remarks there. I wanted to keep this very short and very tight. But as I look across the world, from brand new cities like Neom in Saudi Arabia to countries that are trying to modernize, frame what a North Star looks like, I think these are the types of things that people in control and influence and power has to start to drop into the conversation to make sure that if you're going to build a system, you just don't build one that reflects what everybody else has, but you build one that can actually transcend what everybody else has. I'll move it back to the moderator now. Thank you.
Really appreciate it, Richie. That was nicely done, and I like your presentation style with using the Mobius tool. So that was awesome. So it was good to see it in action. Next, we're going to move into Mr. Dersh, who's going to be talking to us a little bit about healthcare policy to address pandemics and other health challenges. And I want us to think about, how do we want to start changing policies that go across global lines to be able to impact the things that we want to do and help those in the region around us, right? So Dersh, take it away.
Thank you, Oman. Really appreciate it. Really appreciate the invite by the ECCB. It's an honor to be here. And I'm really pumped about talking about some of the things that we see, how we look at the current environment, particularly post-pandemic, and our preparedness and what we can do, not only as a region, but also as global stakeholders, global citizens, to really, transform what we refer to as healthcare to human care. So I did prepare on a brief presentation. I'll pull that up now. Can you see that okay?
Yeah, definitely can see it.
Is that full screen, Aman, on your end?
No, it's not showing full screen to me.
Okay.
Hey, all the way there.
Sorry about that.
No problem at all, Dersh. On the slideshow from the beginning, right, all the way end. No.
Yeah, there we go.
There we go. All right, great.
All right, cool. So our global mission as a company is to really build and deploy technology ecosystems for governments, especially now, I think, in this post-pandemic arena, that has exposed, the chasms that exist, not only from a technology basis, but as we look at it from a health access, health inequities, economies of scale challenges in particular regions across the globe. We are a We're based in the US, but our global headquarters is in Bermuda. And we were the first company to sign entire country around healthcare data, healthcare payments, cross-border care. And that was the country of Bermuda. And we're using that as a microcosm as we're developing and deploying use cases. And now we have footholds in South America, the Middle East, and Africa. So when we look at the infrastructure within healthcare, I think everybody from the Prime Minister to the governor of the bank, they talked about these infrastructure challenges, and I talk about it more in the ability for these infrastructures, the 5 key areas that are on this pyramid of care. I look at it as physical resources, digital data resources, geography, regulatory, and finance. In physical resources, that includes both, healthcare facilities. It also includes, healthcare professionals. So we're looking at not only the human capital, but also the physical capital. And how do we create an environment where that can be fluid, particularly in a region like the Eastern Caribbean? We talked about the centers of excellence, which I think is an outstanding way of starting to build a fluidity of resources around the Eastern Caribbean, as well as even potentially share that across larger region. I look at digital data resources, and a lot of people think that digital data resources are just what's coming out of the electronic health record and what clinicians look at. But we also have to look at the portability of that data around different enterprises, different insurance companies, different borders. How can we make that patient driven? How can we bring other areas of patient data that's not in the EHR? Because that's really the context of your healthcare. And I think we have to build tools as we look at the digitization of this, to make that happen. I also look at geography. The speaker spoke this morning about how can we have a geographic region like you did with currency around care? In my opinion, care should have no borders. That we should be looking at ways to be able to do cross-border care in an effective way, and cross-border care where we have the right regulatory environment, the right data environment, and the right financial environment, which again all takes into the case of how we do this cross-border. We also have to build the right regulatory environment. How do we deal with this data, particularly personal health information, within certain jurisdictions? How can we have cross-sharing agreements, for that data? This is very important as we start building up not only on the personal health data, but even as we look at potentially digital currencies and what that looks like from a regulatory environment, particularly in medical commerce, where it is that closed ecosystem. And then then we look at finance. How are we going to get this done? And that goes not only from an insurance type of mechanism. We spoke earlier about putting together public and private sector type of models. We also look very sharply at things like share risk of cost, value-based pricing. How do we do that in a way that collapse costs, provide better access to care, better access to pharmaceuticals? And I think that's all sustainable with some of the things that we're doing from a business environment, a technology environment, and then a regular framework environment. So we wake up every day, and I think this is very important to the region of all this talk about digitization. How do we get there? and the importance of it in the three stakeholders of medical commerce, and that is providers, doctors, pharmacies, healthcare institutions, hospitals, payers, whether it be government payers or private insurance, and patients. You know, what are those access barriers that happen, and what do we do around this when we are able to create digital identities, you know, amongst that, to be able to cross-share information, cross-share other types of elements that now, you know, increase the cost of care. You know, some studies say upwards to 25 to 30%. So we've one of the things that we brought to market was a credentialing platform that's on chain today, and I think it's very important to think about this not only as a region, but also, you know, as we look at tools like AI and telehealth, and how do we go cross-border? How do we assure that the proper credentialing is in place for our healthcare providers? How do we give that credibility to the populations that this is done? And how do we give that credibility to, you know, countries themselves that you know, they can go cross-border? So I think, you know, our push has been able to talk about it a unified way, where again there's a fluidity of practitioners, that as you know, a hurricane exists in one area, that we can bring those resources, physical resources, you know, to bear, you know, in mental health and telehealth. You know, this is a problem that exists not only within your region, but globally. There's just not enough access in those locales. So how do we do that? But how do we assure that the standards are what you want within your own jurisdiction? And I think we can do that. We can achieve that working collectively by assuring that our provider network went through a standardization, which is then accepted, you know, similar to, you know, what you're doing on the currency union. We also look at cross-border care. You know, it was mentioned earlier that this is a, you know, very high cost, and I think again, centers of excellence is you know, a fabulous idea to try to bring that to fruition. But even in today's environment, you know, cross-border care, not only the cost of it, but also the, you know, how we get that data. You know, it's really crazy that if I'm traveling from St. Kitts to St. Lucia, whether it's, you know, on a business trip, or I'm actually moving, my physical being shows up in St. Lucia. All my belongings show up in St. Lucia. However, all of my healthcare data, everything about me, stays in St. Kitts. I step back and I say, that's crazy. You know, we should be able to build what I refer to as my medical digital twin, that I have access to my data. It's in my data vault. I am then able to give permissionable access to other providers, as well as build what we mentioned, a more robust identity of myself and my electronic medical being, because I'm able to link that to other things like wearables and other types of data sources, you know, maybe climate information that isn't in the electronic health record. So we actually put that on chain today. We did our proof of concept in Bermuda. We built it around a non-fungible token on chain, access through a QR code, where we're able to traverse from different providers, and I could actually take my digital vault, which was the first one that we did, and provide that cross-border. I would also mention that the ability not only to do bidirectional data, but also the ability to do bidirectional payment and bidirectional messaging in a secure fashion is really key as we try to bring all of these component parts together.
Hey, Dersh, we have 1 minute left for you. So just letting you know.
All right, man. Thank you, sir. Yep. So the other things that we look at, where I think, you as a region also, we look at digital health registries. We talked about identities. We think the region can have a big impact in specific clinical trials and telehealth, build the foundation for digital and cross-border care, value-based drug pricings, and build and break down these health inequities that not only happen in the region, but also then globally. And lastly, one of the things that we do with different jurisdictions across the globe, we try to bring together the stakeholders from both private sector and public sector, identify where we think those initial use cases can be to be most impactful, and then drive that through deployments. Did I make it, Aman?
You got it. I appreciate it, Dersh.
Thanks
a lot. Appreciate you providing some details on that and how you're trying to bring things together and the things that maybe some of these jurisdictions and countries want to think about on how to connect with each other for kind of a unified landscape. And so we're going to dive right into some deeper things around data, right? The things that we have. And Ms. Odessa is going to be leading us in on the socioeconomic impacts of public respiratory health shocks in the Caribbean. I'm a big data guy, so I'm looking forward to these next two speakers and to learn more, because with that and what things that Dersh and Richie are doing, there could be some collaboration to make impact in these areas. Ms. Odessa, you're up. So excited to hear from you.
Hi, thank you, Aman. I'm excited to get started. So I'm going to share my screen and we'll walk through the presentation that I've prepared for today. Okay, so good morning, everybody. My name is Odessa Eli David, and in the last few months, I've been doing some research on the socioeconomic impacts of viral public health shocks on the Caribbean region. And I'll just walk through some of my initial findings as the research is still ongoing, but I thought it would be a very interesting experience to be able to provide some information that I've discovered so far in my research. So let's get started. Firstly, I wanted to start by explaining what the scope of my research project is, and I'm talking about multiple things. So I'm discussing the socioeconomic impacts. I'm discussing viral public health shocks. I'm also discussing the impact in the Caribbean region. So there are different things involved in terms of the scope of this project, and the scope is large. But I think it's very necessary to focus on looking at different elements of how things impact society, how health shocks impact society, and not just society, but also the economy. In terms of the health shocks that I'm looking at 6 outbreaks in particular. And then in terms of the Caribbean region, I'm looking at the ECCU countries, CARICOM countries, and regional trading partners, which would include countries like Cuba, for example. So I'm really trying to investigate what really happened throughout the years as different outbreaks have impacted the Caribbean, but also compare them to other parts of the world. So the purpose of my research is twofold. I guess there are public benefits for this research, but there are also personal benefits for me as a researcher and as a person who works in the data space. So in terms of public benefits, it's very important for us to do this type of research to get actual data about the impact of different outbreaks on society and on the economy, so we can make informed policy recommendations. We don't want to make recommendations or implement new policies just based on observation or just based on what we would call common sense, but we want to use data to actually make policy recommendations that are backed up by evidence. So that's one public benefit that I think this research can have. We also want to foster improvements in digital and data infrastructure because through my research, I've noticed that a lot of work still needs to be done as it relates to digital infrastructure or data infrastructure. We want to also foster resilience among vulnerable groups. So for example, as I'm discussing some of my findings, we'll talk a little bit about age groups, and we'll talk about sex disaggregation of data, males versus females, and so on. And we also want to take a proactive approach to problem solving. When things happen, when we experience these types of shocks, in the public health space, we want to be proactive. We don't want to wait around for something to happen, for us to do something about it. We want to take that proactive approach, and because we know that prevention is better than cure, and we just want to be proactive. And for me personally, there are personal benefits, as I am curious by nature. I don't work in the health industry. I also am not an economist, but I'm interested in doing this type of research. I was born and raised in Dominica, so I am born and bred in the Caribbean, and I am just curious to see how these types of things are affecting us in the Caribbean and how we compare to the global market and how we compare to the rest of the world in terms of these types of public health concerns. And for me, this is also a learning journey, because I'm doing as much as I can to take this information and learn from it and see, what can be done. And so this is the real purpose behind this type of research that I'm doing. So as I approached this research, what I did was I approached it with 5 theories in mind. And keep in mind that I'm saying theories because the research is still ongoing, and these are the things that I want to try to prove or disprove using statistical methods and using different approaches to see if these are true, or if, maybe they're not necessarily true. So what I'm doing is fact finding. And I approached it from having 5 theories. One, I think there are similarities between how different regions were affected by the outbreaks. And we'll talk a little bit about each of the outbreaks that I'm referring to. But one of my theories is that there are similarities between regions such as the Caribbean versus our global trading partners, similarities between how we were affected by these outbreaks. Number 2 is that there are differences between how we were impacted by the outbreaks, obviously, because we know that different things contribute to the way countries are impacted, and it's never the same across the board for every single country or for every single region, because the way the US would respond to something is not the way we in the Caribbean would respond to something. So my second theory is that there are differences. My third theory is that males and females were not equally impacted by the outbreaks. The fourth one is that the working class members of society were more at risk than the elderly. And for me, I'm defining at risk as the fact that the working class members of society may have been more exposed to viruses than the elderly for different reasons. And my fifth and final theory is that GDP, unemployment, and tourism were significantly impacted by the outbreaks. And we'll take a look at all of these theories in more detail. So for the first and second one, in terms of similarities and differences between the regions, I wanted to highlight that on the left, we can see all of the regions that I'm interested in. So the ECCU countries, other CARICOM countries, regional trading partners, and then global trading partners and other small island developing states. So these are the regions that I'm investigating as part of this research. And in terms of the outbreaks, I'm looking at the Spanish flu, yes, all the way back to 1918, looking at the Spanish flu, looking at SARS, swine flu, chikungunya, Zika, and COVID-19. So all of these are viral outbreaks that have impacted different regions of the world. And what I really wanted to see is, are there any lessons that we can learn from each other? Can we learn something different between the ECCU countries and other CARICOM countries that are non-ECCU? Are there similarities? Are there differences? And what are those similarities and differences? And how can we learn from each other to move forward and make positive changes to our policies and the way we handle such outbreaks? My third theory is that males and females were not equally impacted by the outbreaks. And what I'm doing here with these charts is I'm showing the cases, and in one case, I'm also showing the deaths broken down by sex. So for SARS, actually for all of the cases that I was able to find the data for SARS, swine flu, chikungunya, and COVID-19, we can see that more females, there were more female cases than male cases. But if we take it a step further with COVID-19, for example, we were able to find even more data about the sex breakdown of COVID-19 deaths. And what we're seeing is that even though there were more female cases than male cases, there were more male deaths than female. And so I think that was a very interesting insight to discover in my initial findings, because it's showing that maybe females and males need to be treated differently or targeted in different ways as it relates to recovery and prevention and so on and so forth in terms of policies and ensuring that we target the right people in the right ways based on how they're impacted by these outbreaks. So that was very interesting for me to discover. And another thing that I discovered when looking at the Spanish flu is that the same trend persisted even way back then. We see historically that in terms of the death rates or in terms of deaths per 100,000 people, when we had the Spanish flu in 1918, more males died than females. And so it just shows that historically, what's really happening. This is a consistent trend. And what are we doing about that consistent trend? Are we even looking at these types of trends and determining what we can do about them? So that's something that I really want us to, to keep in mind. These things are happening and who's paying attention to them? My fourth theory is that the working class members of society were more at risk than the elderly. And from the data that I could find, for SARS, for example, we could see that the median age of the cases was age 49. But for the other outbreaks, it does show that younger people have higher rates of infection than older people. And so this is something that I still have to investigate a little bit more, as I do need some more data on that. But it is a theory that I'm interested in testing by doing, some hypothesis testing and getting some statistically significant differences, if any, for these groups. And something else that I wanted to highlight is all the way back to the Spanish flu. Again, we can see that, before, or we can see in general that there are essentially two spikes before 1918 when the Spanish flu hit. So in 1917, for example, which is the light gray line on this chart, we can see that there are two spikes, for younger people, a lot of high deaths for younger people as well as the older generation in 1917. But in 1918, what we're seeing is that, there was a spike in the number of deaths for younger people between the ages of 20 to 40. So, this also ties into this theory that I have that the working class was more at risk than the elderly because that spike wasn't there before, So this is something worth looking into.
1 minute, Ms. Odessa, just letting you know.
Okay, thank you. So my fifth and final theory is that unemployment was significantly impacted. I won't spend too much time on it, but that is also another theory that is worth investigating a little bit deeper, because we can see that there are some spikes in unemployment during the time period of the outbreaks. But then that is not the same case. For example, in chikungunya, we don't see a spike in the actual year when it was when it was at its highest. But what we do see is that there are some spikes before and after. So, this may not necessarily apply to everything, but again, this is something that's worth investigating. How can we look at unemployment? How can we look at the swings in GDP? We can see that GDP may have been significantly impacted by the outbreaks, as we can see some sharp dips on these charts. And then finally, tourism was impacted by the outbreaks. But what I found interesting is that tourism seemed to be impacted on a larger scale for the respiratory health shocks, so swine flu and COVID-19. but not necessarily for chikungunya and Zika. So it's interesting to see that we need to understand that the way we approach solutions for different types of outbreaks would be different based on the type of outbreak that it is. So just to wrap up, I wanted to say that this research is ongoing and will continue with some additional data collection, some hypothesis testing and modeling. And then I just wanted to wrap up with some challenges and recommendations. So I do think that more data disaggregation is needed. We do need to have some improvements or see some improvements in data infrastructure, more training and education in data collection and collation for health professionals, proper allocation of expenditure to ensure that we are prepared, and then of course resilience. We need to have durable systems, but we also need to have contingency plans to protect the vulnerable based on the facts and the evidence and the data. So thank you very much for listening. This is
Thank you, Ms. Odessa. Yes, data is the driver for a lot of things that are going to be coming up now in the present and in the future. And we're going to talk a little bit more data with Dr. Pilar, who's going to be talking to us about the impact of antimicrobial resistance. So looking forward to this conversation as well. So Dr. Pilar, the floor is all yours.
Can you hear me now? And can you see my screen? Can you confirm that you can see that in
Yes.
presentation mode? Fantastic.
Yes.
So thank you so much, and that really that is a very appropriate conducting flow for this presentation as well. And before starting, I would like to say that on behalf of the Pan American Health Organization Director, Dr. Jarbas Barbosa da Silva, let me thank the organizer, especially the Eastern Caribbean Central Bank, for inviting the Pan American Health Organization, PAHO, to participate in this webinar. My pleasure and my honor to be here and share the panel with this kind of different experts, but very complementary ideas at the end. So this is the outline. I will go quickly. So we hope to have a few minutes at the end for some questions, but we start speaking about the impact of AMR and estimating the impact of AMR, looking at the COVID pandemic and as well some kind of One Health approach and the climate crisis. So you know that AMR is completely invisible, except for the microbiologists, but the impact is not invisible. There is impact in the human lives, in economy, and as well in development. So the really antimicrobial resistance started getting more and more attention after 2015, when the estimates about the burden and as well the economic impact on AMR started in several studies from the UK, and as well there was a lot of attention in the media about the impact, specifically the economic impact. We have to say that. But this situation has been very much aggravated in the first 2 decades of the 21st century with many different crises, the climate crisis, the globalization, the migration, and as well many disasters. So this situation is getting worse along the century. So going back to the impact and looking at the impact in human lives, so that is specifically related to the human health sector, we know that there is an incredible impact in terms of the number of deaths that they are estimated. And recently there was an estimate coming from 2019, that is before the pandemic, that there are around 5 million of deaths associated with antimicrobial resistance. The estimates come from this publication, this paper. This really interesting, and I will suggest that the reading very, very much, and you will see that the Caribbean is located in the mid of this kind of axis, and it is in the middle, and that means that there is a significant amount of deaths for 100,000 population in the Caribbean. Is just in the middle. You can see that it's around. You see that around like 60 deaths for 100,000 population per year in 2019. This is the impact in human lives, but we know as well that antimicrobial resistance has impact in economy. And we were going to see three different aspects in macroeconomics. So this is the report, the very famous report from the World Bank and the World Bank, and we are really appreciative of this report with some very interesting estimates about the impact and as well the impact making the people falling into extreme poverty into 2050 if there is no action to contain AMR. And this poverty will be specifically and much more intense in low and low middle income countries, and as well an important impact in GDP. But as well, as I mentioned, this is pre-pandemic estimates, so probably that should be revised with the new situation about antimicrobial resistance. So macroeconomics, and now we are going to look at the national level. At the national level, as well, antimicrobial resistance had a specific impact, mostly related to the significant proportion of increased healthcare expenditures regarding antimicrobial resistance, longer treatment, longer hospitalization dates, etc. And as well, there is an impact on poverty specifically on the individuals, and as well it's because antimicrobial resistance strikes hardest at the poor, and as well taking into account the situation about water and sanitation, and this is specific hard to reach a safe toilet and clean water, and as well safe defecation. And this is important as well for the transmission of infection and the generation of antimicrobial resistance. So that makes the poverty like a specific, and the people living in this kind of vulnerability conditions, especially vulnerable to antimicrobial resistance. And as well, this is the out-of-pocket expenses that will increase and hit harder to the poor. One important factor as well was the climate crisis, the environment and AMR, and we know more and more the specific impact that we have because of the climate crisis, and we know that as well climate crisis is impacting hardly in the Caribbean, and we know that different aspects of climate change or climate crisis will impact as well in increase the bacterial infection. The increase of infection, increase of antimicrobial use, and increase at the end of antimicrobial resistance. COVID-19 for sure has fueled the AMR pandemic, and as well there is different factors related to the vulnerability of the patients, the antimicrobial use, and as well the use of inappropriate antimicrobials such as azithromycin or hydroxychloroquine. So this was important, and as well you will see there is a situation of emerging AMR pathogens and mechanisms, and we will mention a little bit more in the next slides. We know a lot of different outbreaks in the region, especially in Latin America, but as well in the Caribbean with new emergent mechanisms. We have an overall increase in the reports of multi-drug resistant pathogens, and at the end, we are able to know that this was a higher burden of AMR. So just an example, we prepared this kind of review. This information comes from notification of the countries, information of the countries, but as well from the Caribbean. And it's really, really worrisome that countries such as Belize or Dominican, for one hand, they have the capacity to detect new emerging mechanisms, but on the other hand, this is a very worrisome situation. That is something new that the clinician and as well patient and families should be adapting to this situation. Everybody knows and is aware about the impact on SDGs. This is really the relation between AMR and specific SDGs, not only health and well-being, but as well poverty, hunger, the reducing inequality, and the work and economic growth is related and it's important impact of antimicrobial resistance. So let's move quickly to the response, and as well we are looking at cost effectiveness response. We can have a lot of information coming from this report is coming from the OECD report, and you will see that they are different predicted. So this is as well a model and estimate. You will see that they are different, huge different among countries about the predicted deaths. So this is something that we can do. So it's something that we can have maybe lower predicted deaths, and as well, this is as well related with investment. So basically, the message of this report is that most of the deaths, up to 70% of the deaths can be avoided with investment, and as could be as low as $2 per person per year. And as well, they identify the most cost-effective intervention is hospital hygiene, hand hygiene, and antimicrobial stewardship. So the first two ones, hospital, environmental hygiene, and hand hygiene are very close related to the infection prevention and control. So the investment of on these policies will pay for itself in 1 year. So we need political commitment. This is extremely clear, and I think that it was one of the biggest motors to move the antimicrobial resistant agenda. So antimicrobial resistance has been discussed in the G20, in the G7, and in different international forums. And as well, at the international level, we have now the One Health quadripartite coalition, including the environment, jointly with FAO and WA. This is different agencies, international agencies. So we are working together to provide this kind of support to the countries and as well raise awareness. I must highlight that in the Caribbean, we have one of the champions on antimicrobial resistance from the Global Leaders Group, Her Excellency Mia Motley, Prime Minister from Barbados, and the impact is incredible about how they are able to move forward the international agenda. Caribbean as well, we have excellent examples in the last few years about the impact and the political commitment. I think that my time I am running out of time. So let me just go very quickly. So the importance of the national response. They are, and of course, for sure, my presentation will be available for anybody that would like to know more about that. So the importance of the national responses on AMR, the national action plans, the Caribbean and on track as well in the developing of the national action plan. The big challenge is implementation. That this national action plan should be multi-sectoral. And when we say multi-sectoral, that means a huge range of different sectors. It includes as one of the aspects is including the legislation on antimicrobial use, antimicrobial stewardship, includes surveillance, and Caribbean as well is part of the antimicrobial resistance surveillance in the region of the Americas. We are able to have specific data. We are looking to new technologies as well not only in the Caribbean, but in general, in the region. That is super important to better understand epidemiology, molecular epidemiology, infection prevention and control that should be implemented in all the countries. And as well, there were several excellent examples from the Caribbean, how the countries were able to tackle antimicrobial resistance in spite of the COVID pandemic. So just to summarize, one of the biggest challenges to implement the National Action Plan were the lack of coordination, the lack of funding at the country level. This is one of the message from different international global workshops. And this is important, but as well, the last message for this, that conclusion, is really the relevance of getting better data to respond to specific information needs for AMR intervention and national priorities. So that is my last slide. Thank you to all the contributors, all the countries and participants that were able to contribute to the presentation. Sorry for the rush in the last few minutes, and I will be back to our chair moderator.
Right. Thank you. No, you're great. There's an immense amount of information there, and so we're definitely really interested in learning more, right? And I think you touched on the last part of it, which is going to be my first question. And so I want the rest of the audience that's there, if you have questions, please come up to the mic. If you have questions on Facebook or YouTube, send it over to us, and we're happy to answer them. But I'm going to start off with a question while I'm getting that in there. And that my first question was about data, right? And data. Everybody is talking about it. Ms. Odessa did a presentation. Dr. Pilar is talking about needing more data. We're talking about data from health records. We're talking about data that's coming in from all these different sources. So let me ask you a question, panelists. Whether it's on my antimicrobial issues, what's happened in COVID adaptation, or potentially even new diseases on the horizon, what are the use cases you are seeing that we may not be aware of around using data for improving population health? I think Dr. Pilar would say, hey, we need more data to be able to understand what's going on in these countries, right? From antimicrobial resistance. But what else are you seeing where data can have an impact, right? And how can we work with these countries to provide that kind of impact? Right? I'll start with you, Dersh, since you're unmuted. How about that? So.
I think, even when we look outside the region first, the big data exists, and it's referred to as data interoperability. We've been talking about that for years, right, Aman? And to me, it's more of a competing issue around big data, around conflicts within business competitors. So I think by looking at it from a patient-driven perspective, by being able to derive that data from this, the digital EHRs, and like I was saying before about the context of my data and social determinants of health, I think that that's where we need to get to. The things that I think about too is kind of like, we might be in regions like this to be able to leapfrog and take advantage of the historical challenges around interoperability and data capture. It's almost like leapfrogging right to 5G, right? And I would leave it with this, that whoever said that saying, you can't eat an elephant at one time, right? But you can over, taking, simple bites. And my point is that I don't think we don't need to start an initiative where we say, okay, we need to, the only proof of concept or MVP is to have everything. But if we have a starting point, and I think we're moving to that digitization and we're able to create that in a patient-driven way, I think that's how we get there.
Yeah, I've seen, from my perspective, I think policy gets low attention on this. If you think about the mature countries like the US, it started with, to Dersh's point, started with different companies, right? There's corporate competitive forces in play, because corporations started way before the US government figured out that data was actually a policy issue, right? The US government is now catching up on data as a policy issue. Whereas in the emerging markets, policy can tackle data from the early stages, right? Policy can enforce and incentivize the exchange of data, the standardization of data formats. Policy can actually put incentives in place for people to comply to data integration and data exchange. And I think this is an opportunity for the emerging markets to really think about data as a policy issue early, as opposed to the mature markets who are now kind of reeling in the mud of privacy, trying to address data issues across the board. Second is, I think there is a tremendous amount of data that's already been collected from the mature regions of the world that could infer insights that would be interesting to smaller, less advanced regions of the world. And we saw some of that presented today. Last but not least, the collection of that data and the sharing of that data and the instrumentation of that data, there's only so much the provider can collect, right? The provider can probably collect, 5% of the information about a patient, whereas that public education, that public awareness, that cultural investment from a citizen perspective to say, I'm going to share my data because I understand that this is a part of society. Just like I go to church, I'm going to share my data because it's something that I believe in. These are all unique opportunities. And if you think about the unique set of islands that we have here, these are small populations, right? I was just in St. Lucia a couple of weeks ago. It's a small population, and you see the social campaigns, right? As you drive down the streets, social campaigns around digital data and the collection of it and the sharing of it is probably going to be an important part of this, because you could have all the systems in the world, but if people don't trust that they should report their data, they don't trust where their data is actually going, then you're only looking at what the doctors can collect. You're not getting the real picture from the patient. And so I think it's really important that the citizens themselves feel as a part of the fabric, safety and trust around sharing data with government, because it's not something that people feel today, especially if you think about some of the misuses of social media, et cetera.
Yeah. Ms. Odessa, what would happen if you had better access to data, right? And more prevalent data for the type of research that you want to do?
I think it's very important to do research based on a complete data set, or as complete as it could possibly be.
Mhm.
And I think that, I don't want to make incorrect conclusions based on, lacking data. And I think that is a big risk when it comes to not being able to access data. So we need to have access to the data. We need to have reliable sources that we can depend on to go to and find that data, to fill the gaps so that, things are not missing and pieces are not missing, so we can actually, or so I can actually make the conclusions that I'm going to be basing policy recommendations on, because we don't want to make recommendations with a lack of information. We want to have a solid base to go off of. And so I think that's where it's really important to have a good foundation, a good set of data, a good avenue to collect data and fill those gaps so that conclusions can be complete and accurate, and we can be confident in those decisions.
Nice. Okay, I'm gonna throw in a Zoom question right now for us, right? So the question is, I think that we have significant amount of data, but the way the data is collected is an issue. How do we address this issue of collecting data in such a way that it can be useful to the process of regional sharing? Good question. Anybody want to
I'll take a stab at.
All right, take a stab. Go for it, Richie.
So look, I've done work around data privacy with humanity.co. And for the audience, the thesis there was that human data should be classified as human property, just as our thoughts are classified as intellectual property and we have ownership and property rights on it, the data should be that way. And it's this really complex debacle around the commons versus the individual, where there are individual rights that ought to be protected versus the benefit of the commons, right? If we all share our data, there's a commons market. What it really comes down to is it comes down to that I accept button, okay? When people are asked to provide data, the experience for the consumer, for the citizen, is a horrendous one. It's a 42-page contract that is written in language that they can't understand, that they have to scroll down and then click an I accept button in. And 20 years ago, everybody just clicked the I accept button and that kind of made sense because that's what you were supposed to do. Today, every time someone clicks that I accept button, there's a little person that comes in your side of your head that goes, should I do that? Should I really do that? And so data collection is becoming something that you have to be more transparent about. The I accept button is just not going to scale. And with all the news around data privacy leaks and all the issues around cybersecurity, it's no surprise that we're seeing more and more evidence that consumers are being more suspect of that I accept button. What we ended up doing there was we ended up building a beautiful kind of user interface around it where the consumer had controls to be able to say, I'm willing to share it with my doctor and my region, but not everybody else. Or I'm willing to share it in my region, but if you want to share it globally, please reach back out to me so that I can give you the permission at that point. Now, this is easier said than done. We signed, I don't know, my parents probably signed 5 contracts their whole lives their marriage certificate, their mortgage, their job contract. I sign 5 contracts a day every time a new app I'm clicking I accept. It's easier said than done, but we have to get to the crux of the matter around data, especially in areas like the Caribbean. People don't trust technology enough as yet. And people don't trust their governments in a unified enough way to be able to say, yes, I'm going to give that data. So trust is at the core here. And the way to address that is to demonstrate the value, right? Show the use cases on national television of how sharing of data actually helped, right? Make the case in public discourse of how data helps. I think trust is going to be at the issue to be able to collect the data at scale.
Yeah. Ms. Odessa, this is a question directly for you. All right. So Ms. Odessa spoke about her findings to date about more females than males contracting the SARS virus. Is there a linkage between the use of traditional medicine being higher in females than males in relation to these findings?
So since I am a data person, I'm going to say that I don't have the data on that to say yes or no. But from observation, I do know, and in the Caribbean, we do see that more females are interested, I guess, in healthcare and taking care of their bodies and visiting the doctor and things of that nature. And so we saw that there were more female cases, but then there were more male deaths. And so, could this be related to the responses that males and females have to healthcare in general? That's something we want to answer. Could this be, directly related to the way we take medications versus, males versus females? That's something we would want to answer, So I don't have the data specifically on medications, but there is vaccination data that I do have, and so I'll be taking a look at that, and I'll be taking a look at the vaccination rates and comparing it males versus females and seeing how that influenced or how that could have potentially influenced the outcomes. So I think that's a very interesting question, and it does speak to the differences between the sexes in terms of how we both approach healthcare and different how we both approach healthcare.
Yeah. No, appreciate it. Dr. Pilar, we are living in a world now where antimicrobial resistance is growing dramatically in some areas, especially during the pandemic when a lot of physicians in a lot of emerging markets did not know what to do. They were over-prescribing antibiotics, and so it increased the trend. So how do we start focusing our energy? Where's the first place do we focus on? Is it education? Is it going directly to the health ministries? Is it trying to work with governments to be able to start talking to pharmaceutical companies and saying, hey, don't stop trying to push these kinds of medications to our doctors when you don't educate them appropriately on what's the response. So where do we start? Because you've provided a lot of data to us. Where's the starting point?
Okay, I think that this is an excellent question. So the starting point really, in my very personal opinion, is in the governments, in the national authorities. These are the bodies that they can use the data for decision making. So we were able to know that the increase use of antimicrobials was happening since the very beginning of the pandemic, and a corrective measure maybe could be taken or could be maybe started the discussion with the clinician and other professional societies. So national commitment and national ownership on the data and the use of the data for decision making is key, And in that regard, there is additional information that is coming from surveillance, from the microbiology lab, and as well we need to ensure the quality of the data and the representativeness, so the data will be valid to take a decision and to suggest decision, strengthen the capacity of the microbiology lab to better detect antimicrobial resistance, and then educate the clinician, the nurses on infection prevention and control. And so you see, this is a multifaceted, multidisciplinary aspect, but don't forget the One Health approach, and as well, don't forget as well data coming from other sectors, human, and for sure beyond the human health, right? Animal husbandry, veterinary medicine, as well. This information should be integrated, analyzed jointly from the public health perspective. So data is key. And it is really a huge responsibility for the governments.
Yeah.
Over to you.
Yeah, thank you. So I wanted to ask if there was a question from the St. Kitts audience. If Dr. Marissa, you could let us know if there's a question there. We're happy to take one. If not, I've got a final question, and then I'm going to let our presenters do their final 30 seconds.
There's one question. Go ahead.
Please.
Yeah, greetings. I'm here representing Rastafari and also St. Kitts National Men's Council. Now, in relation to the data, and I guess I don't remember who mentioned anything about NCDs, but I would like to ask if there's any data in relation to mental health in the issue where the debate about gain of function research. If that is so, then mental health now seems to become a very scary issue because it seems like just one person having a mental breakdown can release deadly viruses into the air and kill millions of people. So, and then follow up to that, NCDs, which accounts for over 41 million deaths annually, comparing to COVID, which is like about 2 million annually. Is there any data for the NCDs, the way that we are collecting data for these viral issues?
Anyone want to take that? Ms. Odessa or Dr. Pilar, would you like to talk about the NCD data, right?
Yeah, maybe I can very briefly mention that as well the Pan American Health Organization through the NCD programs and as well the mental health program are collecting data. This is much more complex than the mandatory surveillance for communicable diseases. So this is a younger data set, but the countries are more and more reporting on NCD and as well the risk factor related to NCD. And as well, yeah, mental health is key, and as well we are now getting more and more data coming as well for the impact of the COVID pandemic on mental health. So this is ongoing, and that should be as well considered as public health data.
Yeah, let me follow that by a personal thing. So I have been working on mental health data, right? You know, over the last couple of years, especially post-pandemic. And there's a massive problem globally, right? One is the ability to capture that data very quickly and succinctly. Most of the tools out there are very long, and so it's difficult to get that data in a quick manner. The team I've worked with as an advisor has been able to do data capture within 90 seconds or less, but it's still, the other problem you have is stigma, right, with mental health. There's so many countries where mental health is not talked about because if it becomes out in the open, it becomes a shameful thing, right? And we have to be able to start telling people and educating our own populations that it's okay not to be okay, and it's okay to be able to ask for those help, right? And so it's always, I think mental health data is going to be probably the youngest of all of them out there. In fact, I've had conversations in the last 6 months with 3 of the largest healthcare organizations in the United States, and they point blank told me, they said, it is a massive problem, but we don't want to know about it because we don't even have the resources to address that problem. So that's a huge issue too. And how can we look at from the ECCU to be able to create a zone where not only we can capture that data, but also to be able to say through telemedicine, if one island has or one country has more assistance from psychologists, psychiatrists, can't we use telemedicine to be able to project that into areas that are not? And so we have to think about this regionally and globally, not just in our individual areas, right? So mental health data is always going to be a challenge, at least for the next coming decade, I think. So. All right, so I have a last question for us. Thank you for that question. It is definitely a big question, right? So last question for us is from Facebook, which was, how important is disaggregation of data for driving development of health policies? That's a deep question. I like it. So anybody want to talk about using data for driving health policies?
I'll just give an example and wrap up. So I'll couple it with another question that we had here over Zoom over prevention that was posed specifically to me. And to think about data from a unique perspective as it relates to policy. prevention specifically to me is the big opportunity, probably second only to mental health. And I'll give you guys a quick story as I wrap up. I used to eat a corn muffin every day. Every day. I just love corn muffins. I don't know why. I came to the US, I had a corn muffin for the first time, and it was my thing. I would eat it every single day. Are good. Yeah. And about 15, 20 years ago, I go to Dunkin' Donuts and they start putting the calorie count next to the corn muffin. And I saw that the corn muffin that I was eating was 570 calories. And I was blown away because I'm like, it's corn. I mean, it's corn, it's a muffin, it's not chocolate, it's not sweets. How could it be bad? Right. And obviously, I don't eat a corn muffin anymore because it's probably one of the most unhealthy things you can eat in the morning because it's really, really unhealthy for you. It was the US government that mandated that the calories had to be posted on certain types of foods that led to that public awareness that has changed how we eat in the US. Now, we've still got a lot of ways to go to be able to get that done. But as we think about the emerging markets, politicians and policy can influence things like that. I'd love to see the same type of things in the Caribbean where the amount of calories has to be posted on food, for example. And that's data. That's data being used in a completely different way for a completely different purpose and in a way where you don't have resistance, right? Because you could pass that policy and it's very easy to just write it in what the calorie count is and to mandate it. So I'll just say that all of this stuff coincides together and it requires the types of conversations like this and a holistic point of view to be able to find those unique opportunities where you can really drive change. And I would say, if it wasn't for me finding out that a corn muffin is 700 and 570 calories, I would probably be 40 pounds heavier right now and way more expensive to the healthcare system.
Nice. Thank you. Thank you. Thank you for that. Dr. Pilar, last comments. I'll give you 30 seconds to finish up and just make a what is the quick point that you want everybody to take away with?
No, absolutely. It as well is about the sharing data, the ownership of the data, and the way that the countries, the governments should be able to use the data for making policies. And as well, we as researchers and as well specialists in medicine, we need to translate the data for actionable activities. So that is my final comment. And as well, I just for your information, I upload my presentation in the chat in case that it should be or could be distributed to the audience. Thank you so much, Aman.
Thank you, appreciate it. And so Odessa, final comments. It's the last 30 seconds you want everybody to walk away with.
Yes, well, I want everybody to walk away with the idea that data is everywhere. Data is important in making decisions, especially fact-based decisions. And I really want to say a special thank you to Miss Patricia Welsh, who has been really guiding me through this process, because I think with doing a project like this in terms of doing research into the economy, into society, into public health, for someone like me who doesn't have a background in any of these things, it just goes to show that everyone can participate in solving problems that affect all of us, and that we do need guidance from people who are willing to help and provide the expertise and the knowledge and the domain expertise. So thank you to Ms. Patricia Welsh, and thank you to everybody for listening.
Dersh, final question, final thoughts?
Final thought is we're all in this together, that the issues that we've talked about today are not unique to the Eastern Caribbean. And I think that we can use this as, again, another microcosm where we can build those frameworks of how data is shared based on those pillars that I talked about earlier. And I think it's even though it's challenging, I think at the end of the day, when collectively we can figure it out, it's great for the individual, but also great for the greater good of the society.
Yeah, no, I appreciate that. And my final thought is going to be, think about this, right? We are talking from everything from antimicrobial resistance to innovations in healthcare. And the thing you have to think about is all of them can work together. The key is bringing everybody together to think about our healthcare holistically from a standpoint of being proactive rather than reactive, and being able to bring the right data points to say we can start our education processes early so that our young generation doesn't face the same issues that we're facing now, right? So with that, I'm going to give it back to Dr. Marissa to be able to take it on to the next break and into the next panel, and appreciate all the panelists for joining in and participating. It was a good experience, and I'm excited to learn more about what happens over the next couple of days. Thank you.
Thank you.
Let's give another round of applause to Dr. Aman and his panel for what was an incredible and power-packed presentation on a whole. Unfortunately, we had a few more questions coming in from our St. Kitts audience, but because of what is the time limitation, we are unable to answer those questions at this point in time, but we would encourage you to submit these questions in writing form, and we would try to address them before we go our ways for the end of the day. At this point in time, we would encourage you all to take we invite you all to take a short break, just about 5 minutes, so that we can stretch our feet, get a little drink, move around a bit, and we ask you to be back in 5 minutes so that we'd be able to continue with the proceedings of today. Thank you.
The 7th Annual Growth and Resilience Dialogue 2023 welcomes you to 2 days of enlightening healthcare discussions and innovative tech ideas and exhibitions.
Register for free via ECCB's website to join companies, specialists, thought leaders, disruptors, and transformers that are passionate about issues that are key to your health and well-care needs and challenges.
The fact of the matter is that almost 8 in 10 deaths in our region are attributed to non-communicable diseases.
Feel the rhythm, feel the vibe. 40-40, long time. Feel the rhythm, feel the vibe. With the CCB for a lifetime. ECCB 40, yeah, yeah. Long time. Oh. Celebrating 40, yeah, yeah. Long time. For day, long time, feel the rhythm, feel the vibe, with this CCA for a lifetime. Everything is up, we making impact with the cash, digital currency. Quick to react, so we could relax, and that is fast, reliable. The ECCB protects you and me in each and every it's to see you country. Strong body, my currency, and full of power and energy. Oh yeah. ECCB 40, yeah, yeah. Long time up, boy. Celebrating 40, yeah, yeah. Long time up, boy. 40-40 wait for 40 plus. Education, wealth creation, teach transformation. The ECCB protects you and me in each and every ECCU country. Regional brilliance and vigilance, oh yeah. ECCB 40, yeah, yeah. Long time ago. Celebrating 40, yeah, yeah. Long time ago. Feel the rhythm, feel the vibes. 40, 40. Feel the rhythm, feel the vibes. With ECCB for a lifetime. ECCB, our financial guide. Side by side, we go much with pride. ECCB, our financial guide. Side by side, we go much with pride.
The 7th Annual Growth and Resilience Dialogue 2023 welcomes you to 2 days of enlightening healthcare discussions and innovative tech ideas and exhibitions.
Register for free via ECCB's website to join companies, specialists, thought leaders, disruptors, and transformers that are passionate about issues that are key to your health and welfare needs and challenges.
The fact of the matter is that almost 8 in 10 deaths in our region are attributed to non-communicable diseases.
Feel the rhythm, feel the vibes. 40, 40, long time. Feel the rhythm, feel the vibes. With ECCB for a lifetime. ECCB 40, yeah, yeah. Long time ago. Celebrating 40, yeah, yeah. Long time ago. Feel the rhythm, feel the vibes. 40, 40, long time. Feel the rhythm, feel the vibes. With ECCB for a lifetime. Everything intact, we making impact. With the cash, digital currency. Quick to react, so we could relax. And that is facts. Reliable, the ECCB protects you and me in each and every ECCU country. Strong polymer currency and solar powered energy, oh yeah. ECCB 40, yeah, yeah. Long time ago. Celebrating 40, yeah, yeah. Long time boy. Feel the rhythm, feel the vibes. 40, 40, long time. Feel the rhythm, feel the vibes. With ECCB for a lifetime. Always coming through for us. A central bank to trust. 40 with no fuss. Can't wait for 40 plus. Education, wealth creation, teach transformation. The ECCB protects you and me each and every ECCU country. Regional brilliance and vigilance, oh yeah. ECCB 40, yeah, yeah. Long time, oh. Celebrating 40, yeah, yeah. Long time, oh. Feel the rhythm, feel the vibes. 40, 40, long time. Feel every day, feel the vibes. With ECCB for a lifetime. ECCB, our financial guide. Side by side, we go match with pride. ECCB, our financial guide. Side by side, we go match with pride.
We now invite our attendees, our in-house attendees, to return to your seats so that we may proceed with today's event. Thank you.
The 7th Annual Growth and Resilience Dialogue 2023 welcomes you to 2 days of enlightening healthcare discussions and innovative tech ideas and exhibitions.
Register for free via ECCB's website to join companies, specialists, thought leaders, disruptors, and transformers that are passionate about issues that are key to your health and well-care needs and challenges.
The fact of the matter is that almost 8 in 10 deaths in our region are attributed to non-communicable diseases.
Can we have our attendees returning to our seats?
And Resilience Dialogue 20 welcomes you to 2 days of enlightening healthcare discussions and innovative tech ideas and exhibitions.
Register for free via ECCB's website to join companies, specialists, thought leaders, disruptors, and transformers that are passionate about issues that are key to your health and well-care needs and challenges.
The fact of the matter is that almost 8 in 10 deaths in our region are attributed to non-communicable diseases.
Neuroscientific research has proven that dopamine, the neurotransmitter that is essentially our chemical messenger of that feel-good sensation, and it has proven that music is in fact one of the greatest sources of release of this chemical messenger. So we're going to invite Mr. Nikhil Rogers from St. Kitts as he presents us with a musical presentation.
Good morning, Growth and Resilience. As mentioned, my name is Nikhil Rogers. It's a pleasure to be here this morning. I'm tasked with the responsibility of burning off some of that sugar that you guys are drinking and eating from your break. And lighting up those neurons in the brain with music and movement. So I'm going to be giving you a rendition of a song that I wrote some years ago entitled Wine on Me. And now we're going to incorporate you guys to be my choir, be my band as well, because it's just me up here. All right, we're going to start off nice and slow, and I'm going to build it up with this pedal that's on the ground, which is a loop pedal. Wine with me. Just build your energy. Wine with me, wine with me, wine with me, wine with me, wine with me. Come here, my people, clap all your hand and wine with me. All right, I know some of you are in here right now, but sing along with me. Sing this with me. Say, ooh. After me. Ooh. Can't hear you. Say, ooh. Yeah, ooh. 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 Say, wine. Wine. Say, clap. Clap. All right, clap now. Clap, 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 clap. Yeah, I see you staring at me with those seductive eyes. I stand up on the stage and I cannot disguise feelings I feel. I'm gonna reveal with just one clap and dance in my seductive song. Wine with me and recreate this energy. Just wine with me, wine with me, wine with me, wine with me, wine with me. Yo, come here, my people, put up your hand, them. I see you staring me with those seductive eyes. I stand up on the stage and I cannot disguise the feelings I feel. I'm gonna reveal with just one clap and dance in my seductive song. Oh baby, wine, 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 wine with me and recreate this energy. Wine with me, wine with me, wine with me, wine with me, wine with me. Yeah, throw up your hand and move all your foot and wine with me. Everybody, let's clap. Here we go. Clap, 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 clap. All right, now I want you. So now we're gonna be dancing. Y'all are gonna be up in there and dancing. But what I want y'all to do is rock with me now. We're going to rock left and we're going to rock right, all right? Let's get involved. Let's burn out some of that sugar, all right? Let's go. With me, moving left first and then right. Let's go. Move right, rock left, rock right. Rock left. Everybody, don't be afraid. Rock right. There we go, double time. Left, right, left, right, left, right, left, right. All right, all right. All right, love to hear everything I've been hearing this morning, all right? And one of the most important things that I think is that, it's all about movement. One of the things that we started slowing down with from teenage years, and especially with all the AI and technology, is that tech has taken our place in this world, and we do less and less. We walk less, we move less. And music is something that activates the brain and activates the muscles. And when you activate the muscles, you use up all that glucose and all that energy that's just storing and causing all the havoc that we deal with today. So always remember, guys, to move and enjoy life. Music combines the two. My name is Nikhil. Thanks for having me.
Thank you, Nikhil, for that awesome presentation. And let me ask you to give what is also to a round of applause for what is the technical team of the Eastern Caribbean Central Bank, who have been doing a splendid job. The level of preparation is truly amazing. One of the other things, too, that I wanted to highlight is that they truly have what is a very holistic approach to the theme of this GRD. Through the break, we were actually treated with healthy smoothies. So actually, we did not have the sugary snacks. But we did have what was natural smoothies provided to us. And of course, too, we also just had what was a wonderful presentation in terms of musical therapy by Mr. Nikhil Rogers. So again, let's give them a hearty round of applause. So we will now be moving into our next panel discussion. Before we get there, I'm going to again remind us all that we are inviting questions. We had a bit of cold feet here in the St. Kitts audience, and so the questions started coming in a bit late. And by that time, then most of the questions had already been addressed to the online audience. And so then we would encourage you to pose your questions early so that we would be able to allow your full participation in-house as well. We are asking you, of course, to reserve the questions until all of the panelists would have presented, and similarly, once it is that you indicate that you have an interest in presenting, then we would identify or notify you so that you would be then able to present to what is the closest mic to you. Our next presentation, or panel discussion rather, panel 2, and the theme is exploring the potential of traditional medicine as a game changer in the Caribbean: health promotion, disease prevention, and treatment. So again, that is exploring the potential of traditional medicine as a game changer in the Caribbean: health promotion, disease prevention, and treatment. And our moderator for panel 2 is none other than Cyril Brown, the indigenous bushman, herbalist, holistic health educator, and researcher.
Thank you, Dr. Tate. Good morning, everyone. Glad to be on board.
Good morning, Cyril. And so we also have joining Cyril. We have as well on the panel, we have the Right Honorable Priest Kalish Leons, CEO of the Mount Kaliash Rejuvenation Center, St. Lucia. We invite as well Dr. Valma Jessamy, resident scientist of the Greenville Vale Tropical Botanic Garden in Grenada. We also invite Dr. Guido Marcel, climate-smart agriculturist, ethnobotanist, and pharmacognosist of Dr. G's Garden, Grenada. And so now I will hand over to Cyril to lead by moderating the second panel discussion. Thank you, Cyril.
Thank you, Dr. Marisa. Greetings, everyone, and welcome to panel 2 discussion. But before we begin, let's take a moment to acknowledge our audience and our panelists. And we are really excited you were able to take time from your busy schedule to be with us this morning. And as Dr. Marisa mentioned, our theme this session is exploring the potential of traditional medicine as a game changer in Caribbean health promotion, disease prevention, and treatment. My name is Cyril Brown. I'm also known as the Indigenous Bushman. I will be your moderator for this segment of the discussion. I'm an herbalist, holistic health educator, and a researcher. So since we only have about 60 minutes to discuss these broad topics, I'm going to keep things brief. All right, but before we bring on our speakers, I really want to encourage our listening audience to have questions ready for our panelists. And we'll have answers for you when we open up the lines for some questions and answers. So without further delay, ladies and gentlemen, please, to enlighten us on the tradition of healing in the Caribbean, help me welcome the Right Honorable Priest, Kailash Beyonce.
Yes, bless the Lord, give thanks, Honorable. I'm just going to share my screen with all protocols already established. Give thanks for all delegates, give thanks for the people that's hosting us, give thanks for the audience. Last and not least, the first really is give thanks to our creator for actually being with us in this space. So definitely, my name is Right Honorable Priest Kailash Beyonce, who is the CEO of the Great Physician International Mount Kailash Rejuvenation Center. And also, I am the founder of the Mount Kailash School of Esoteric Knowledge. In our presentation today, what we are going to be specifically dealing with is the tradition of healing in the Caribbean, a look into traditional medicine, folk and alternative medicine. Even previously, while many of the other panelists spoke, there was the speaking of data and the critical nature of having data. And when it comes to data of what you call traditional healing, this is one of the things that I would say is within our midst. Yet still, even when you look at the different realms of medicine, that type of data probably was passed on from the great-grandmother to the grandmother, then to the mother, and then to the child, is one form of data that's normally not looked upon as what we refer to as scientific information. And within our presentation, what we'd like to do is just to showcase how it is that the use of traditional medicine, folk medicine, alternative medicine, also the challenges to it, the opportunities, and we are going to conclude where do we go from here and also where do we get our information. Even before I speak, what I would like to do, just because we have to sell traditional medicine to our policymakers. Why? Because what we find is happening today, it's that the herbalist or the herbal healer, the traditional healer, whatever he claims that he is doing, one of the key things that will be said is that there is no scientific information. So let us begin by just listening to a client who probably had been trying to conceive for over a decade. And after just going through a traditional means of healing, that she was able to conceive. So let's listen to the words. So they say out of the mouth of the patient, so at least we would have a greater understanding.
And issues having Kayla having a baby. I went to Honorable Miss Kailash, and he gave me the woman package and so many other things to come along with total treatment and taking care of eating certain food and taking care of the body. And within 3 months, they came care.
Give thanks for life. How old?
After Kailash.
So, as we saw via the caption, because they say, well, 65% of people who look at videos don't even listen. They just read the caption. So we captioned it for you. We are talking about one person who's not able to actually conceive and go through a specific process, and they're able to conceive. And that is one out of hundreds of people who have actually went the traditional route and basically have been able to conceive. So isn't this enough reason that even to ask a scientific question, what modality of medicine was implemented? What is it that actually caused this person that was not able to conceive to be able to conceive, and then urge even our policymakers, our educational entities like the University of the West Indies to begin to dig deeper even in the use of our traditional medicine to help to eradicate disease. So traditional medicine is basically what we'll refer to as the type of medicine that we have been utilizing over the past 400 years within the region. Because we're talking about the Eastern Caribbean, so you're talking about a space that was originally populated by the Amerindians. And eventually, through chattel slavery, we had our African brothers and sisters and the indentured servants from India, from China, from all around the world actually came to work within the region. So the medicines that we have available, the type of herbs that we have available, the different modalities of implementing these herbs don't just originate from the region, but it is a bouillon, as they would say in St. Lucia, of a large range of medicines like your gully root, your cassia lata, the Spanish needle, what they call Biden spilosa. All these different herbs originally coming out of the west coast of Africa, India, and even from Europe being utilized to treat diseases. Then we have what you call the folk practices, or what people call your voodoo and your obia and all these different types of practices that people actually look down upon. But if it is then, now, as we are in the present state, we understand that scientifically, that many of the so-called things that we call occult, many of the things that people would describe as conspiracy, many of the same things, even your mental health. Right now, mental health has become this key discussion. But even before, when you tell someone, okay, well, you are what you think, they would think, well, okay, well, this is how you are what you think, you are what you eat. So it is critical that we understand even these spiritual practices, how it actually affects the endocrine system, how it affects the secretion of cortisol, or how it affects the secretion of dopamine, oxytocin, how it affects the production of serotonin, how these practices affect the overall bienestar, the wellness of these clients, gives us even the responsibility to actually look back into these traditions and see how we could create a more what we refer to as a patient result-oriented system. So as one of the speakers before said, it's not the healthcare system, it's a healing system. And we have what we call the alternative medicine, and alternative medicine specifically looking at the whole range of acupuncture, as people would say, homeopathy, cupping therapy, and all these different types of naturopathic healing. But we must critically understand that being in the space of the Eastern Caribbean, we are ranked as number six in 25 countries, where we have the widest assortment of what we refer to as global biodiversity. That means that we are a hotspot not because of 5G or 3G or 2G, a hotspot because our herbs, the biodiversity of the herbs that we have can be utilized as what we refer to as a foundation, whereby our intellects, our scientists can come into the communities, do the research, and are able to actually create even potent pharmaceutical drugs to actually take care of our diseases, also validate the traditional uses of these medicines. It is very critical that we understand that even the whole aspect of what we refer to as folk medicine, we must not just take it and dash it away, because within wellness is not just something that you just push aside and say, okay, wellness is whether you feel good or whether you feel bad, no. As the World Health Organization said, specifically, it is not just your physical, but your mental. Look at the whole aspect of what is referred to in the Afrocentric realms of medicine, of the interconnectedness, and also from the center to the circumference. How is it that you as an individual, your overall well-being, how does it affect the well-being of your community and your country specifically? So when we look at the whole realms of folk medicine, it is critical that we study it. Let's look into it. Let's look at what the people call the voodoo and the obia and see how these things there could be utilized to uplift our system. Now, I'm going to play another clip because, as I said, we have to literally make people, because one of the key things that people say is that there is no herbal medicine or traditional medicine. It's not an evidence-based medicine. But yet still, if you just type in on your computer and say scholarly articles, Biden spilosa, what they call Spanish needle, or you say scholarly articles, Petivera alicia, what they call the Guinea hen weed, you would find tons and tons and tons and tons and tons of scholarly research material, even patents for this herb to even be used in what we call the treatment of cancer. So let us for 1 minute listen to what this client suffered from and what she was able to accomplish.
Blessed loves, greetings from the beautiful Bahamas. My name is Rhonda Ingram. And in
Kailash, we have 1 minute left.
I was
Yes.
diagnosed with cancer for the 3rd time. Chemotherapy was not the route that I wished to take. And after conducting some research, I decided that my choice would be to visit the Mount Kailash Rejuvenation Center in St. Lucia. At the mountain, I received natural herbs, everything from God's natural garden. I'm rejuvenated. My spirituality is uplifted. I am energetic. I am a brand new being. And I want to simply give thanks to the entire team at the Mount Kailash Rejuvenation Center for taking such.
Yes, so I actually gave my 45 seconds of my last minute to our sister here, just to express the benefits of herbal and traditional medicine. So we know cancer is basically killing us. So if it is that you have one person with 4th stage cancer who would actually go through a process, and after going through a specific process, it shows that specifically that person could have benefited from that process. Then it means that it gives us reason to delve deeper into these processes and see how it could benefit us as a whole. So in conclusion, my last 15 seconds, where do we go from here? It is to create spaces. The photograph you see is a photograph of students who actually come into the island of St. Lucia, specifically to study herbal medicine, but not only herbal medicine just as in the aspect of the herbalist, but also studying the basic sciences of what we refer to as the medical school, and be able to utilize that knowledge to create a new set of people who can implement our traditional, folk, and alternative medicine. People who have that level of knowledge of the physical structure and could use it to actually naturally eradicate disease. So where do we go from here? We make traditional folk medicine something that is documented, something that is researched, and something that could be validated scientifically and respected throughout the region and throughout the world. Blessed love.
Thank you, Honorable Priest Kailash. Your message was well received. Thank you very much, sir. And now, to explain the advantages and disadvantages of traditional medicine usage, please help me welcome Dr. Palma Jessamine. Dr. Jessamine. You're muted.
So I take it from the top again. Good morning, welcome. Let me go right ahead and have you get my slide. You can allow me to share my screen. I must thank Governor Timothy Antoine and all of the team from the Central Bank for elevating this topic of traditional medicine or green gold to this platform. Very often when we think of traditional medicine or healers, we start thinking about the words bush doctor and quacks and obia and all of that actually comes from a long history of disenfranchised through the colonial period. And I'm not going to give you a list of advantages and disadvantages. I will take you through a story in space and time. I would try not to repeat what you would have heard earlier today from most of our speakers, but give you some hope that we can have a reimagined future and our traditional medicine will be part of this resilience, this game changer. Now, our last speaker did touch on the fact that the Caribbean is this West Indian medical complex. But our history is not one that begins with Christopher Columbus in 1492. We are not a depeopled region. So when we are very proud about, traditional Chinese medicine or Ayurvedic medicine from India and other regions, we have yet to name and to own and claim all that came out of this great West Indian medical complex when we had a mixing from the Kalinago, the Saramaccan, the Amerindians, the Garifunas people, and all of this exchange that happened with Europe. This great West Indian medical complex is best expressed in the work of Dr. Pablo Gomez when he speaks of the experiential Caribbean. So one of the major advantages is the fact that a lot of this has already been worked out. If you go back to the work of the Jesuit priests, you would see that they would have spent time with our indigenous peoples. The idea that Africans came to the Caribbean only in the 18th century and so during the enslavement period is actually false. And Dr. Gomez paints a picture of the Black Caribbean healer who was filled with power and knowledge. In that time period, you had lots of free Black peoples, or medical doctors and practitioners were paid for their healing work. If you read the work of Sloane from the 1670s, and that of the Royal Botanic Gardens, which he's famed to have started, you will understand that plants are still relevant as cures. This here is a photo of a honeybee on the flower of what we call bloodroot, which is a medicinal plant. And we have been able to trace the phytochemicals from many of these plants into our honey. Again, there was the mention of the Caribbean being one of the hotspots because our biodiversity is under threat. If you go back as far as the 17th century records, you would find copious books on our medical plants of the Antilles. Guava here, for instance, is listed for its medicinal benefits for fertility. Guava is known to help increase testosterone and wellness in women and both men. Guava increases the sperm count in men. We also know that the guava leaves are used for many healing properties. So it's well documented that plants such as the arrowroot, which is a fusion of African and Amerindian knowledge, plant-based cures, were used for its healing properties when persons were recuperated in the plantation hospitals. And Hans Sloane, who worked in Jamaica for a very long time, between 1687 to 1689, has described quite a lot of those healing remedies that he's famed for, but he learned it from our peoples. We know that arrowroot is also good as an antidote for poison. So we have this long, long history of documenting our traditional medicine and the cures. Take, for instance, Guayacum officinal, which we call the tree of life, is described by Columbus in 1492 in his voyage log as a cure for syphilis. We think of the Caribbean plantation agriculture only around sugarcane and coffee and cocoa, etc. But tons of medicine was exported to Europe and other parts of the world from the West Indies. In 1952, a lot of things happened. With decolonization, a lot of what we call traditional cures the chemistry was worked out. So you can go to PubMed, for instance, and find validation of the phytochemistry and the pharmacological properties of much of our traditional plants. So it has been validated. Guaifenencin is the active chemical from Guaiacum officinal. Unfortunately, this plant is now on the IUCN Red List and endangered. This is a native plant of the West Indies. It is the flagship plant of Jamaica, for instance. Now, our traditional knowledge was used for resistance, and today we're talking about resilience. If you read the work of Weaver, Medical Revolutionaries, the work of Laura in The Secret Cures of Slaves, she described the 18th century Caribbean, where our women healers, or the men too, were able to use the traditional knowledge for resistance. So that women were using this plant, which is the native plant of Barbados, as an abortifacient. They did not want their children to come into slavery. And so a lot of the early work in fertility actually started in the Caribbean because there was this dilemma. Why is it we cannot have natural increase of the population? And it's because there was resistance. The healers were able to either reduce fertility, abort fetuses. They were able to make the entire plantation sick and know just what to give them to recover. So that resistance resulted in lots of agnotologies and barriers in the transfer of knowledge, which is why we have this crisis in present 21st century, as opposed to regions such as China, in which the traditional medical cures are a part integrated of the health delivery system. As early as 1767, there were laws prohibiting Amerindians from providing knowledge of plant cures to the African peoples. The reports of all the cures were authored by Europeans. Imagine, we were banned from reading and writing. And so this oral tradition, as well as the fact that Negroes were banned from practicing medicine, contributed to this idea of our healers as involved in dark art of Obio and Voodoo. And so it became an underground science where keepers of the secret. So I'm going to move forward very quickly because of time. And I would not go into some of what I wanted to say because it got captured by many other presenters, to give you a little bit out of a case study. And this is a time presentation, so I have to just go quickly. I have been working with honey, and we were able to track the phytochemicals in the honey to many healing plants. We were able to look at the antimicrobial profile of some of the specific honeys that we are able to produce and see that we have very high actually the honey is able to, the bacterial kinetics show that we have very high antibacterial activity. We were able to do the phytochemistry and trace this back to the plants. And so we were able to develop 35VX, which has 35 antivirals from our team of biomedical scientists, biotechnologists, and chemical engineers who work with 17th century cures, which is the company that I head. We have worked with a medical doctor here, and we're actually doing a lot of groundbreaking work where we are healing wounds, including diabetic ulcers, with our traditional medicine and honey cures. In closing, we need to decolonize our food and agriculture and healthcare system. We do not have any herbal gardens and proprietary planting schemes, and so based on the phytochemistry and pharmacological properties of our plants, or farming techniques are such that we are getting rid of a lot of our healing plants. We need nurseries and conservation seed banks. Everybody's backyard in the Caribbean could be considered a virtual pharmacy. The food that we eat is medicine. These are some of the ingredients that is typically used in a grenadian oil down. In there are lots of herbs, including turmeric, which are known for the anti-inflammatory, antibacterial, and healing properties, antioxidant properties.
Thank you, Dr. Jessamy. We appreciate the time here. Job well done. I wish we had more time. Hopefully in the future we get a lot more time allotted to our discussion, but I appreciate you very much. I will talk to you at the end of the discussion.
I just want to say that you can go to our website, Sustainable Island Living, where you can get some of the presentations that we have been doing on decolonizing our food and healthcare system, food as medicine, antibacterial resistance, and using our native herbs and plants. I thank you.
Thank you. Well received. Thank you, Dr. Jessamy. Before we move on to our next speaker, I wanted to touch just a little bit on some things that Priest Kailash touched on, especially when it comes to men's prostate health. He didn't go into detail because of the time limit here, but just a gentle reminder that Guadeloupe and Martinique in the Caribbean are actually #1 and #2 respectively when it comes to prostate cancer globally. Okay, and then we have islands like Barbados, and we have the Bahamas and Puerto Rico following suit. So it's one of those situations where it's very sensitive, and we need to take a look at that more, okay? So our final speaker, but not the least, this morning is going to enlighten us on how can we advance research in traditional medicine. Please help me welcome Dr. Guido Marcel. Dr. G. Dr. G, you're muted. And while Dr. G is getting his Zoom launched, Dr. Jessamy talked a little bit about arrowroot, and arrowroot was back in the day a baby's formula.
Yes.
When I grew up, there was no baby formula. We had arrowroot. Arrowroot was what it was every day, every morning, and arrowroot is plentiful in the Caribbean. It's loaded with vitamin B6, and it's really great for mental health. All right, so we need to look into those things and capture everything and bring more awareness and education to our people in the region. Dr. G, are you available yet? Okay, Dr. G is still trying to connect. Very interesting dialogue so far, guys. It's wonderful. It's great. As an herbalist myself, for the past few years, I have worked with many clients, and I've seen wonderful results. So we need awareness, I've always taught, and then education. Okay, when it comes to traditional medicine, traditional healing in our region. And I think that is going to uplift us as a region and as a people in a whole, right? In the whole scheme of things. And we need to recognize that herbal medicine is what it should be, and we really do need to surround ourselves with all the our people who are knowledgeable when it comes to traditional medicine. Dr. G, let's get you going here, sir.
Okay. I ain't seen my presentation, I ain't seen my presentation.
You're not seeing your presentation?
Yeah.
Do you not see your slideshow? Dr. G, do you want to share it, or is this something you can you can get into without having it shared on the screen. I think Dr. G may have disconnected here again. Dr. G, the ECCB can share it, so we could have that going here for you so you could get your presentation going, okay? I think Dr. G.
Yeah, let the EECB share it and I'll speak, yeah. So.
Okay. And they have it. Just give us a moment. We'll bring it up. So very exciting and informative dialogue so far. This is great. And like I said before, I wish we had more time to hear from Priest Kailash. I followed Priest Kailash for a while now on his YouTube channel, and what he has to bring to our awareness, it's a lot. It's very vast. And Dr. Jessamy as well. I've been following you for a minute, and Dr. G, back.
Screen is up.
Start to talk.
Have they put it up?
If you don't see it, I don't think so. I think they're still working on it.
Ooh.
What can you tell us, Dr. G, before your screen comes up?
Okay.
What can you share with us?
Basically, I was looking at the research needed for us in this particular region to marry our traditional medicine to our healthcare system. And there are a number of areas we would have to augment or build on so that we could be effective in that regards, okay? There is the broadcast or regional definition of traditional medicine, which was covered by my other colleagues, so I wouldn't go into that. And implicitly, it also mentions mental health. So into taking into consideration anything about our traditional medicine, we must be concerned about mental health issues. Also, we have to, if we are going to make policy and procedures, we have to look in totality at the variety of preparations that are coming out from traditional medicine. In other words, we harvest different parts of the plant. So we must have maybe regulation and laws that impinge on those. Like it's coming up.
Looks like it.
Like it, yes, okay. Yes, so I'm saying we must look at the totality of the different preparations that could be made from all the different plant parts. So if we are going to move into any regulatory mode, we must have information to cover all these. Can you put it on screen? Oh, yes. So let us quickly, we leave the definitions because the definition is universal.
Do you have a good view of your presentation there in the
Yes,
east?
I was seeing it here, but it's off again. Okay, so one of the things we would have to do in the region is to set up regional entity, or maybe a regional entity, to deal with the whole incident of traditional medicine. And I suggest that maybe we would have to look into maybe setting up a coordinating agency, a regulating agency, a national advisory committee, a system to monitor, particularly any adverse effects that may be coming out of the use of traditional medicine. In other words, we need to have some pharmacovigilance. And this is very important because we must know what is happening at all levels and at all times. So one of our guiding principles in moving forward, it should be evidence-based, and we should be emphasizing safety and efficiency in any of the products we are going to use in whatever form they are, be they teas, elixirs, alcoholic preparations. We must be cognizant of their safety and efficiency. We must be able to consolidate data from what existed before, and we must do this in a rigorous way, and we must be supporting new research. Additionally, some first steps. We must have a total assessment of traditional medicine and practices as they now exist in the region. And if we want to make linkages and integration, we must therefore know how this would interact with our current healthcare system. For surety, having ensured that safety and quality and efficiency is there, we must make sure that this does not hinder the patient choices. And also, traditional medicine in no way must be involved in a higher cost. There must be the balance of costs. The patients must be able to get reliable information. So the major areas we would have to look at is legislation and regulation of products and practices. We must expand our education to be totally holistic, starting from the individuals in the household, to the community, to the nation, to the region, to maybe all the stakeholders that are involved. We must also be very rigorous in our training and in the licensing of products and practitioners, as well as being extensive in our research and development. We must take time off to have linkages with all the institutions that are involved in this regard. We then would have to decide what is the choice we are going to make. What type of system would we copy? There are different examples of system. There's a tolerant system, there's the inclusive system, and there's the parallel system. The integrated system, however, is the one that is used by China, Korea, and Vietnam. And they have expanded their system to include regulation, registration, also involved in the education system, their universities, their hospitals, as well as all of their other training institutions. And finally, I would like to say that our approach to dealing with our traditional medicine in the region, we are not starting from scratch. So we are building on what we have. And to build on what we have, it must be quality-based. And there are a number of areas we must become very serious about documenting and having information on and following modern and contemporary procedures. For example, as mentioned before, traditional knowledge and documentation. We have to become very rigorous. Almost all the information that is in the region, we must have a hand on it. what has been done in the past, what is being done. We must have our institutions an institution dedicated to that. We must have reference to pharmacopoeias and think in terms of developing our own pharmacopoeia for the region with detailed monograph of the plants that we have. We must also become very rigorous in our botanical definitions so that we know we are identifying the peculiar plants that we are dealing with or the peculiar plants we have in the regions. Also, our macroscopic and microscopic definitions of the articles that we have in our traditional or herbal medicine practitioners, we must have detailed information on those. We must be able to identify our phytochemical markers so that we know precisely what are the drugs we are dealing with, and using modern and contemporary technologies to identify the active ingredients, or if not the active ingredients, but the markers in the plant. We must, I say, do these particular interventions to have a fuller understanding of where we are and where we are going. And this may lead us to having maybe developing proper bioassays and then the proper reporting of maybe any trials that were done, that have been done. I think we have to put into place very rigorous reporting systems that will exchange the information among us so that we could all understand. So we must be very broad-based in a delivery. We must be very broad-based in our documentation. We must be able to share information. We must be able to recognize all the stakeholders at play so we can build on the institutions that we have and build on the education in totality, starting maybe with all the peoples in the region and also incorporating what has been done external of the region. So that is part of some of the things I wanted to share with you at this time.
Many thanks, Dr. G. We appreciate your time and your wisdom. At this time, we would like to go ahead and take any questions that we may have from our listening audience.
We have a question from St. Kitts.
Yes, thank you.
Okay.
This question is for the lady that presented second. I don't have the name before me. What's her name?
Dr. Jessamy.
Jessamy, yes, thank you. I'm actually interested in the honey conversation. Here, we do use Manuka honey for diabetic wounds, and it's actually very effective. But that's the only honey-based treatment that we use. It comes from New Zealand. It's very expensive. So the fact that you have one or a type that has the same and that has similar antimicrobial properties, I wanted to know if any studies were done to compare the efficacy of yours versus the Manuka honey to see if it could get the same level of international acceptance.
Dr. Jessamy, you are muted. You are muted, Dr. Jessamy.
There we go. I can ask you to reshare my screen so I can properly answer that question for you. Okay. So this slide here shows the bacterial kinetics, of our honey as compared to Manuka as a positive control. And what we have found is that several of our varietals actually outperform the Manuka honey. This work was done by a nanobiotechnologist, Dr. Pradhan, at the Indian Institute for Technology over a period of 4 years. We have looked at the intact honey. There are several mechanisms by which honey imparts its antibacterial and other properties, and it's because of the phytochemicals. There's one that is because of hydrogen peroxide. There's a hydrogen peroxidase reaction that takes place with honey, but there are also some other reactions. And what we did was to neutralize several of these pathways and then compare our honey again. Manuka honey is in that table, and so we were able to do the comparative of the different varietals as compared to Manuka. And we've developed something that we have trademarked and we've filed patents for, our phytomed factor. We were able, with the mass spectrometry work, to actually identify several of the chemical markers in different plants. Manuka based its healing properties on MGO. MGO is cytotoxic. MGO is methylgoxal. It's a breakdown product in the honey. It's sort of just before you get to the alcohol stage from sugar. And some of our honeys actually do have MGO, but our healing properties of our honey does not depend on MGO. It is because of a range of phytochemicals. And because of that, our honey has shown much wider spectrum of antibacterial, antifungal, anti-inflammatory. We've even looked at the antioxidant profiles as compared to ascorbic acid, which is one of the strongest antioxidant, and our honey outperforms. And I've got more graphs and charts to prove this. We are actually just preparing some scientific papers for publication. We've presented this work to Epimondia. We're getting ready to present again to the next Epimondia in a few weeks of our research. Epimondia is a scientific commission on honey and beekeeping in the world. And so we have done and answer the question that you're asking. Now, on different islands, there are different plants. And so honey, and in different zones within islands. So honey is biogeographic, meaning it's specific to the geographic region. And it's possible to change your botany of an area to develop proprietary planting schemes, as we have demonstrated here at Jessamine Eden. So you can have specific plants that have these properties that the bees have done the formulation for us. The bee formulation is very safe. The bees have worked out how to combine these phytochemicals and have it in a very safe balance. I think I can stop here for now. Thank you.
We have two more questions in the audience in St. Kitts.
Hi, good day. My name is Ellen Arteton. I'm actually Grenadian by birth. Dr. Guido Marcel was actually one of my mentors. So my question is, how can we as a region introduce pharmacognosy in like high schools? I did it as a part of my pharmacy program because I'm a practicing pharmacist. I realized a lot of the knowledge on our herbs, bush as we call it, is not passed down as it should be. And a lot of the times the actual names, the international names is not known. We only use the colloquial names that we have here in each island. I think it's a good program to introduce into high schools so that everybody could be educated on the herbs available, how to use them, and that way we can tie it with our regular medicine. If it's one thing I must acknowledge, Dr. Drew was one of the doctors, our Prime Minister, who would normally introduce supplements, herbal supplements, along with his prescription medication, and you actually saw better results from the patients. Thank you.
Thank you. Priest Kailash, is that a question you want to answer for us?
Oh yes, give thanks, my beloved brother. I was telling you your mic was muted a while ago also. Knowing that 6.7 million people actually died with diabetes, I say, that was in 2021, I said. They said, I saw on a paper. And even in St. Lucia in 2006-7, we were named #1 in the world. And according to predictions, in a decade, it would have actually doubled and would have become 50% more diabetic cases. With education and the utilization of programs within the school system, if you look at the top 10 countries in the world with diabetes, St. Lucia is very fast, not even in the top 20. So there is the possibility that with proper education, that when it comes to the non-communicable chronic illnesses, we could actually get proper results. And why is it then that we have to juxtapose our traditional ways with what is happening internationally? If we look at in 2015, a Nobel Prize was won by Dr. Yu from China, using a plant called the sweet wormwood to create an anti-malarial medicine that actually saved plenty of lives in Africa. And the only reason why her way was actually feasible was because she utilized it. She did her extracts utilizing the traditional methods that were utilized in China. So I find it that it's imperative, knowing that even when someone has leukemia or lymphoma, Hodgkin's or non-Hodgkin's lymphoma, and they have to get a dose of chemotherapy that might cost them thousands of dollars, and yet still we have plants right here within the Caribbean region that contains vincristine, vinblastin, the same drugs that we actually import, that rises up our healthcare bills to the roof. Why then is it not that our traditional ways respected to the extent that whatever knowledge that we actually have, that our people within the universities could study these phytochemicals, give some significance and importance to what our ancestors did, not just the fact that it contains a cetiterpine and it's an antimicrobial, or it contains polyphenols, but what were the modalities of extractions did they use? Why did they use 3 leaves? Why did they use 5 leaves? Why did they remove the center vein of the plants? Only to find out that after further studies that the center vein might contain more alkaloids that might be more cytotoxic. So why don't we utilize all this information to create a healthcare system that I would say that is what we call result-oriented? And instead of having a herbalist, our course that we teach produces what you call a herbal physician, because we find it that it's imperative that instead of isolating the scientific information, you have nanobiology that is critical, right? We utilize the knowledge of the medical practitioner. And instead of saying we are independent, we become interdependent. And one more point I just want to address on the previous presentations, when it came to the whole realms of what we refer to as data, the significance of data. In speaking in a method that would actually benefit the patient, we understand that there is something called data mining. So that means that data has an intricate value. So how is it then that when we begin to collect all that data from the Eastern Caribbean and the value of that data to the pharmaceutical companies, to the different companies, sometimes data is sold, passed on to insurance companies, how then can we monetize that data and utilize that funding that you gain from all that data to re-inject into our healthcare system to help to boost up what we call the survival of our people in a healthcare system that we know, if we critically analyze it, we say we need help. So the present healthcare system, we need help. So let us look at our traditional, our folk, in our alternative medicine, and like in St. Lucia, we have what we call an allied council. Let us begin to get respect from the national insurance, from the insurance companies, to say, well, even if I went for a scientific study, even if I went to medical school, but I choose to actually study herbal medicine, why is it then that the massage therapist or the acupuncturist is claims, and the person who chooses to do that Why is it then that that's ignored? That as a practitioner doing your craft, and a client comes to you, even if they are concerned, the cancer is not there anymore. Even if that they were infertile and it's healed, they cannot claim from the insurance to get these benefits. Let's get to the economic aspects of it and how it can benefit us as a people. Bless it.
Thank you, Priest Kailash. We have about 6 more minutes for questions. And I'm going to read one here and let me know who wants to take it. And this one is from St. Vincent and the Grenadines. And they're saying that the question is, apart from St. Vincent and the Grenadines, what other countries produce arrowroot on a large scale? Most countries use it for starch. How can we proliferate its medicinal benefits? Who wants to take this one? Dr. G, Dr. Jessamy?
Okay, I would answer it here. Not many other countries produce arrowroot in the region as extensively as St. Vincent. And I think the production in St. Vincent has dropped. But we always knew that it was very useful in the diet of infants, young ones, and in geriatrics. It is easily digestible and makes fibers readily available for the microbiome and things like that. I think it's an area that has the potential for further development and also maybe for the creation of new products coming out of arrowroot. I think it's one of the crops that has been neglected to a certain extent, and agronomic research and also further creation of new products have not gone into it. I think it's an area we need to look at, considering what is happening with our food security, and especially since it's a kind of crop that marries over the ages.
Thank you, Dr. G. And we have another question here. And this one is from Dr. Gerald Thompson. He's a physician and he's the CEO of the MCA in St. Vincent and the Grenadines. And he states, while I am so pleased to see traditional medicine being accepted and promoted at this high level of ECCB and the value of local plants and phytonutrients in our diets, the greatest hindrance may well be policymakers and physicians like myself. Unfortunately, there has not been substantial training in med school in this area. How can traditional healers, herbalists, and neuropaths and other similar disciplines become formally registered in more Caribbean islands, as presently they are not able to do so?
Allow me to make a plug for my sister, Dr. Gilberta St. Rose in St. Lucia, who is trained in what we would call conventional medicine, but she's also trained in herbal medicine, and she has her wellness center in St. Lucia. She produced Eden Herbs, and she's doing wonderful work. She's also involved with Tramil. I'm sure Dr. Guido Marcel knows her very well. They've participated on some of the panel discussions that we've had during the COVID lockdown. So I'm sorry she's not here with us today. There's also another fellow woman scientist out of Dominica. And that is a very good question. I do not present myself as a traditional healer. I work with a team of specialists. As Dr. Guido would tell you, pharmacognosy and the work requires cross disciplines. As an environmental scientist, I've been able to develop the healing, the gardens, and conserve the plants. And that work together with the honeybees has led me to the 17th century Negro Materia Medica. So it is a valid question. I think that persons like my another colleague, Dr. Tristan Smith, who is a well-respected cardiologist, interventional cardiologist in the US. He heads up a treatment center. He is from Grenada. He's a member of our board of directors of our center. And on our website, you would get some of his thoughts on the subject. Dr. Smith is trained in phytotherapy from Cuba. So we have the foundations for doing this in the Caribbean. And I think the dialogue today starts this conversation at a higher level to elevate the work that practitioners are doing underground, for want of a better term. During the COVID pandemic, when we talk about resistance, a lot of the voices were hushed. People were put into the quack box when you started talking about herbs and healing. We've done work with our chemical engineer who shows that some of the herbs that we have here in the Caribbean had very high docking when we did the molecular docking with the SARS-CoV-2, the proteins of the virus, and that's why the honeys and so were working in people's speeding up recovery.
Thank you, Dr. Jessamy, for lack of time, and we were extended a few more minutes, so we are able to take maybe 2 more questions from St. Kitts. Let's take one more from St. Kitts, and then I have a question coming directly to the Honorable Kailash. Let's get someone from St. Kitts on the line.
Good afternoon to everyone. I have a question for Dr. Marcel. You indicated in your presentation that we should marry traditional meds and healing with our current healthcare systems. But based on my experience, I recognize that the insurance companies does not cover you when you've gone to the herbal medicine, the herbalist for the meds and care. How do you presume that we get this marriage that you suggest?
Yes, well, essentially that was the challenge that I faced, to present. So we are at the point, I think, in a development now where we have to put systems in place. We are lacking the systems that would encourage or answering the question that you asked. We need to develop the legislations and regulations that encompasses all the bodies. In other words, we have to respect the traditional healers and practitioners. We have to be able to be in a position to certify them or license them, and this should be from a position of knowledge, okay? So once we must have the necessary committees and organizations in place, either at the national level, so the countries could start it as a national level, but I think there should also be a regional body that is looking at this in totality. So we should be looking at the legislation, the regulation, encompassing also the education, the training, okay? We also have to look at, if we're going to be using these plants or plant material, are we considering the conservation, the cultivation, the agronomy? What is happening maybe with the potential for the pollution? This is something also what is happening with climate change. If we want to use the products, yes, how would climate change affect some of the things that we may be wanting to use? So you see, it has to be a total approach. It has to be a total approach. And I think the governments, the practitioners, the health personnel, the consumers, the insurance people, the institutions, researchers, even the legal people, the laboratory analysts, all have to get on board in some way or the other to integrate this into a system. The benefits are known. So the thing is, how can we maximize the use of what we have in the region, benefit the livelihoods of our people from now and generations to come? So it's a decision I think we have to make and build upon.
Thank you, Dr. G. Let's go ahead. We have one person holding in St. Kitts. Let's go ahead and take that question, and then we'll move to the other question for Honorable Priest Kailash.
Okay.
Go ahead, please.
Greetings. I will not be too long because I think the doctor there would have just made some suggestions in terms of what I was concerned about. Maybe first and foremost, we need to start to think of the traditional medicine, not so much as the alternative medicine, because it is really not the alternative. Maybe that will give us a greater push into how we deal with it. If we are going to focus on the herbs, it's very important that the production of the herbs be specially recognized, in that herbs need to be organic, and once we start to get into cultivation, we will be tempted to get into the use of chemicals, and I think that in itself would affect the efficacy of the herbs. Respect for traditional healers and practitioners is okay, but as was mentioned earlier, the legislation must support this move. I, for one, suffer greatly. Not even Social Security would recognize when I go to a herbal practitioner. So this is not something that we need to wait for the next 5-10 years. This is also something that is needed yesterday, because of the increase, as we mentioned earlier, of people into herbal medicine. We need some serious intervention, even at this moment. Give thanks.
Thank you. Who wants to take that one?
Yeah, if I may make a comment, it's interesting that we were supplied some information by the ECB about from the ministries of health of most of the islands in the ECB. And interestingly, in their health report for their budget, no mention, I didn't see anything talking about traditional, which was very interesting. They were talking about the health policy, but there was no mention at all about traditional medicine. Okay, so that is very, very informative. Yeah, they didn't take time off, and this is something I think coming from these discussions that must be now interjected into, once we're talking about health policy for the islands and for the region. Yes, consideration must be given, and even a line or two, a paragraph must now be interjected. Yes, in these presentations.
Thank you, Dr. G. Priest Kailash, that's a question specifically for you from a YouTube audience. And they're asking, can you elaborate on how you see the best way forward for us within the Caribbean with our rich culture of traditional healing, given the variety of ailments plagued in the region, as was highlighted by the moderator in the case of prostatic issues in Guadeloupe and Martinique?
Give thanks, Honorable, and also give thanks again for everyone present, and just acknowledging all people of prominence within us, and those people on the digital waves listening. Even as we go to the whole realms of the question that was asked about the arrowroot, if it is that we really look at the health or the wellness industry as a money-making industry, and stop looking at it as if it's something that is derogatory, something that is supposed to be ashamed about and push it in the corner. The baby food market is $1 billion market. The amount of baby foods that we actually import within the region is astronomical. So for what reason would it be like common sense to initiate, to build up processing facilities? I thought that COVID would have showed us, gave us an example of what we refer to as what they call a chain, something chain, when you delivering things, you can't get your things because those ships coming out of China and yes. So I would have thought that this would have given us a heads up and say, let us look within and see what we have that we could actually keep the food up on our table. I believe that the way forward is look from within, just look from within. What is it that we have within the region that could actually serve us better? For instance, you have lisinopril, which is basically a hypertensive medication that is prescribed to many of us as African people of African origin within the Caribbean. We know that it works upon the renin and angiotensin system. So that and we know that the black man and the black woman has lower levels of renin and angiotensin compared to different races. So we understand that basically the efficacy of this drug would not be as significant as probably Spanish needle or a little parsley juice that are electrolyte sparing diuretics, or a little stinging nettle, you know, or a little vervine. So if it is that we are honest with ourselves, and instead of saying, well, oh, there's no scientific evidence and there's no scientific evidence, we begin to dig deep into the scientific evidence, get that evidence, and see then how we could begin to think about, let's make the money. Let's not send our money over there, and begin to create herbal mixtures, supplements, and even go as far as utilizing our labs. Why is it that we have no pharmaceutical companies within the region producing drugs for our own people? You know, so even if I am a herbal physician or I would give someone a herb, why is it then that with all the intellectuals and all the Nobel Prize winners and all the scientists we have that's running big enterprises, we are not science-driven within the Caribbean region? So I'm saying the way forward is this. Let us institutionalize the whole aspect of herbal medicine. Let's start from the school. So when St. Lucia was number one in the world in diabetes, we know diabetes is a lifestyle disease. That means the first thing you must change is a lifestyle. So what we did, we had inter-secondary school cooking competition, plant-based, right? So people, you would only look at plant-based eating like as if it's a Rastaman thing. So we had to bring it into the school. It's not a Rastaman thing, it's just, okay, look at all the studies outside that shows that, okay, all right. Bill Clinton did it. He had free bypass surgeries. He had to go on 100% plant-based disease and he saved his life. So why is it then that we can't implement that within the school system? Then legislation. You must have legislation, right? And it is not that you're saying, well, everyone could just go and pick a bush and make a tea. We develop a system of accreditation, a system of learning, a system of validation, a system whereby you could say, well, if this herb grows by the roadside, it might contain particular heavy metals. You're not supposed to use that. Get our agricultural laboratories to test the herbs, organize it. Let us just get scientific. And as we said during the SARS-CoV-2 epidemic, we said that let us follow the science. Let's follow the science, right? In Jamaica, Petiferal Alicia Guinean weed is used to treat prostate cancer. Yet still Jamaica is among one of the leading countries in prostate cancer into the world. Let us follow the science, meaning let's use the scientific knowledge on the herbs and the traditional way of using these herbs and implement it scientifically and conduct studies whereby we could, for our own self, not to compare it to the honey over there, but for our own self to bring down the propensity of particular lifestyle diseases and also communicable diseases within the Caribbean region. Give thanks.
Thank you, Honorable Priest Kailash. We appreciate it. At this time, we have no more time for questions. So we are going to invite our panelists to present a 30-second closing remark. Let's go ahead and start with Dr. Jessamy. 30 seconds, Dr. Jessamy.
Thank you. I want to say that this opportunity to elevate the dialogue on the use of traditional medicine for our resistance, resilience, we cannot not have the right framework in place for us to do so. But at the same time, we do not want to create such a formal system where the average household, the individual, is not aware of how food could be used as medicine, how all of the plants in this virtual pharmacy that we live in could be used. We need to look at a benefits sharing mechanism. We need to embrace the NIAO protocol and other protocols in place for patent rights, for protecting our biological diversity, and for using this from our ancestors to forward us into a healthy 21st century.
Awesome. Thank you, Dr. Jessamy. Dr. G, 30 seconds, sir.
Okay. I think we have to give consideration to nutritional security, our health security. And in that regards, I think we have to consider total education. We have to create the linkages that are necessary, create the legal infrastructure that are necessary, follow the models and analyze the models that we have, but become creative in our own right and utilize what we have maximally. Put our best institutions to work to solve the problem for us and deliver for us in totality as the region.
Thank you, Dr. G. Priest Kailash, 30 seconds.
Yes, I'm honorable. Give thanks again for life and a mighty life giver. As a Rastafari, we are accustomed of being what we refer to as the elephant in the room. So traditional medicine is the elephant in the room, the things that's right there, no one is saying it. So let us spell pharmacy, not with PHARMACY, but FARMER space SEE. And let us see that our food really is ultimately our medicine. So basically, let us just start from within and then go without. Give thanks again for a divine opportunity and give thanks to have the moment to sit with you, esteemed people, and for the patient listening rapport of attention. Blessed love.
Thank you, Dr. Kailash. Priest Kailash, appreciate our panel, our speakers. I'm going to take 30 seconds to just elaborate a little bit and talk about my story. Just 30 seconds, I'll be over. I suffered with mental depression in my early 20s, and I'm not hitting on, medication, but medication could not help my problem. My mom, she was a nurse back then, and being the herbalist she taught me, everything I knew about herbs, and she was able to completely heal me using plants. Okay, using plants. So my 30 seconds are over. That's my story, really short. And I just want to thank our panelists for your contribution and sharing your experiences, your knowledge and wisdom with us today. I believe that we leave here today more informed and wiser than we came. Thanks for your efforts. At this time, I'm going to thank also our audience for your participation, all your thought-provoking questions and comments you presented to our speakers today. And Dr. Tate, take it from here.
So that was definitely an exciting and very passionate discussion, would you say? Yeah? Okay.
Yes, absolutely.
So thank you, Cyril, and the members of panel 2. We definitely would have been able to perhaps go on for the rest of the day if we were to have the time to be able to do so. And I'm certain too that we had quite a bit of questions that were still coming in. But nonetheless, we will head straight into what would be our third panel for today. And that will be headed by the moderator, Michel Emmanuel. He has a Master of Science and PhD in Botany and Horticulture. He's a lecturer and Botany Garden Coordinator in the Department of Life Sciences at the Faculty of Science and Technology at the University of the West Indies, Mona Campus, Jamaica. The theme, developing the Caribbean medicinal cannabis industry. So if we thought the conversation was heated and passionate before, you can imagine where we are going next. He will be accompanied by Mr. Kelly John Glass, the CEO of the K Group from St. Vincent and the Grenadines, by Dr. Kadamwe Knaif, lecturer and researcher in the Mona School of Business and Management at the University of the West Indies, director of the Center of Entrepreneurship, Thinking and Practice, CEPT. Also too will be joining Mr. Terrell Mapp, who is the Chief Operations Officer of the Medicinal Cannabis Authority. So we will start off with Mr. Michel Emmanuel. Thank you.
All right, thank you very much, Doc, and thank you very much for inviting me to be part of this important discussion, particularly within the Eastern Caribbean region, where we know that cannabis does play a very important role, particularly within the traditional economy and within subsistence farming. So just to put this panel discussion into context, where the Caribbean region, we know, has had a long, malangled relationship in regards to cannabis. So the ethno-botanical relationship that exists within cannabis and the Caribbean people has seen, from the arrival of the indentured laborers to the birth of the Rastafari movement to the war on drugs sponsored by the United States government to the development of regulated cannabis industries today. So with the advent of the global business of cannabis, where does the Caribbean region stand, and how do we develop the interconnectedness in understanding the regulated cannabis markets that will facilitate trade and the development of local sustainable industries via cultivation, via processing, and to the dispensation of cannabis products. In the region, cannabis is probably the most intra-regionally traded horticultural commodity and catches the highest economic value within its raw state. However, we have traditionally producer countries and we have traditionally consumer countries. So understanding the economics and resource sharing within the OECS is going to be critical in establishing a sustainable value chain that will contribute sustainably to the development of the region via contribution to GDP and its contribution to health and wellness. However, we must not neglect our artisanal cultural relationship with the cannabis plant. So I would like to introduce my first speaker, Mr. Kelly Glass, coming from St. Vincent and the Grenadines.
Hey, good morning. Well, it's good morning here. I'm in New Zealand and it's 3 a.m. But I'm heading back to St. Vincent tomorrow. My name's Kelly. I'm the founder and the owner of two cannabis-related ventures, Medicinal and Greenhouse Cafe. These companies fall under our mother company, K Group, which has a wide variety of businesses from hospitality, construction, boatyards, marinas, and that type of thing. But today, I'll give you a quick introduction on the cannabis industry in St. Vincent and the Grenadines, discuss how our two companies have contributed to the cannabis industry in St. Vincent, and finally discuss other ventures where cannabis industry and hotel tourism and health tourism intersect. I'll be walking you through the slides, but please take a look at the pictures and other information on the slides as I talk. Here I've added a wide variety of cannabis industry stakeholders in St. Vincent. First, we have the government agencies that govern the industry in St. Vincent. It's regulated by the Medicinal Cannabis Authority, the MCA. And the MCA works under the Honourable Minister Saboto Caesar. So about 150 cultivation licenses were given to traditional farmers, local persons and companies. We've cited a few here alongside it with us, Green Lava, excuse me, Kana, SVG and Caracan. Dispensing licenses are separate from the cultivation and manufacture. Here we have Greenhouse Cafe's logo, the first consumption lounge, and that also includes a dispensary. The government of St. Vincent and the Grenadines passed the SVG Cannabis Industry Act in 2018, where they included the decriminalisation of up to 2 ounces of cannabis flower for personal consumption. They also described the access of medicinal cannabis and the different licenses involved in the supply of medicinal cannabis from cultivation to manufacturing, import and export. While the Act does not directly touch on tourism, there's many opportunities that can be found in the legislation for medicinal cannabis in St. Vincent, with dispensaries, consumption lounge and wellness centres, to name a few. How exactly can someone legally buy medicinal cannabis in St. Vincent? So there's multiple steps that have to be followed, and it's not as simple as one might think. You must qualify for at least one of 20 medicinal conditions recognized by the MCA, that's pretty much a no-brainer. You have to book an appointment with a doctor that's authorized to prescribe medicinal cannabis. Your prescription will be issued via your doctor. The doctor will also give you a medicinal certificate and temporary medicinal cannabis ID card. The cost of consultation varies from one doctor to another. The foreigners must also pay 55 extra EC to the MCA. You fill your prescription at an authorized dispensing pharmacy, and you obtain your permanent medicinal cannabis ID card by visiting the Medicinal Cannabis Authority who are out in NMs. And the cost of the permanent card is 20 EC dollars. So to sum it up, a tourist will pay between 40 and 100 EC dollars for a cannabis consultation, 55 EC to the MCA for a card, and between $15 and $200 for products, hopefully. So due to the prohibitive costs, a lot of cannabis users turn towards the cheaper and easier access, which is the black market, to supply their cannabis products. It also takes a lot of transport and time to do every step. So it's been quite a slow start, but we're working very hard with the government to find solutions. And we're already working towards finding some of them, and I'll present one of them later. So it's pretty onerous right now, but I think if we include self-declaration, which we're seeing being discussed in Antigua, I think that's a really good step to expediting it and really making the process so much quicker. So let's move on to the key players in the industry. Obviously, Medicinal is one of them. Medicinal's a fully integrated company from seed to sale. Until recently, Medicinal was the only cannabis legally available in St. Vincent. There's two others who have recently joined the market out of the players that were mentioned before. Here listed are the first bigs, the big first, of Medicinal for the cannabis industry in St. Vincent. So a second player here is in the industry is the Greenhouse Cafe, the first cannabis consumption lounge in the region. It opened in May 2022, and will soon celebrate its first year of anniversary. One of the first goals, one of the major goals of the Greenhouse Cafe team was to create a safe, convenient, and fun environment for patients to enjoy the benefits of medicinal cannabis. Greenhouse Cafe was previously Greenhouse was set up as a cannabis clinic where patients can do all of the complicated steps described previously in one location. A doctor is present to meet the patient. The MCA has representatives present that can prepare you an MCA ID card for the patient, which is similar to a driver's license. The patient can buy their products at this location as well as consume in a safe and charming environment on the beach, looking at the ocean at Coconut Grove Beach Bar in Canash in St. Vincent. So it's a great environment. The Greenhouse Cafe also started to do mobile clinics outside of the Greenhouse Cafe hours and location to meet more people. We participated in pop-ups and festivals, which helped to create awareness and visibility, as well as reach more tourists who go on vacation in the Grenadines. We've tried multiple times to get to the cruise ship berth, the cruise ship tourists, but we're yet to get there. But we are working with the government closely on that. Greenhouse Cafe opened a second branch very recently in Bequia, which is a major milestone for us, as we wanted to increase our footprint outside of the mainland and wish to continue soon into the Grenadines, into the southern Grenadines. We'd actually like to expand regionally and internationally. So if there are any policymakers out there, please open your doors to our SVG organic products regionally. So hotels in Bequia and Kanawha started to incorporate CBD products in their spa treatments to offer to their guests. And it's expected that more and more hotels and spas will follow the lead and offer treatments such as massages, hair masks, facials that incorporate CBD products. CBD massages are in high demand, actually, due to the many physical benefits that you can reap from having a massage, a CBD massage on your skin. It helps to alleviate inflammation, reduces pain, and blood pressure. It's great. The THC, we have a THC topical as well, which is being used by prescribed clients, and it's having extraordinary results with arthritic joint strains and recurring injuries. In fact, our CEO has used it. It's neroli infused, so it smells very pleasant. But she strained her knee and used the THC infused topical on her knee and had very, very good results. So Soho House, which is a hotel that operates in Kanawha, went deeper into the cannabis venture by producing CBD infused menu, using our medicinal CBD tincture. The cannabis infused products are being more and more popular worldwide, actually, with CBD infused drinks, food, and the new way of clients consuming CBD in a healthy environment and enjoying the health benefits of CBD. THC infused products are also widely available on the illegal market, but have not yet broken into the legal market in St. Vincent. But they're certainly out there. So finally, let's go over the possible future ventures of our group, which we're investigating now. My team and I see unique tourism opportunities surrounding the cannabis industry right now, where St. Vincent could be leader, not only in the region, but in the world. So, for example, first, buds and breakfast. Hotel owners are always looking for new ways to bring guests. In St. Vincent becoming a cannabis destination, hotels must adapt to allow their guests to safely and legally consume cannabis. What if you can enjoy the benefits of medical cannabis in the comfort of your hotel room? Guests seeking both privacy and medicinal cannabis of our medical products, such as tinctures, lotions, and capsules, have been shown to provide relief and pain and relief to patients using them. Secondly, tours. Tours are a fun and accessible way for tourists to learn about cannabis industry in St. Vincent. At K Group, we're getting ready for the 23-24 touristic season by building tours around our cannabis facilities. If people want to know more about the cannabis cultivation and manufacture, but they're not interested in consuming it, it's an ideal touristic experience for them. At our extraction facility, we built in a visitor's corridor where tourists can see inside our lab without stepping in, so to speak. They can be educated in our processes and have our scientists run them through the steps of production without being a potential source of contamination for our products. Because in our GMP compliant facility, we first have to gear up before we step into a positive air pressure lab. So, obviously tourists cannot venture in there. So finally, it's wellness centers. St. Vincent and the Grenadines, St. Vincent Cannabis Industry Act includes wellness centers, and we've not yet explored this option and are encouraging other companies to apply. One, to pave the way for new ventures, wellness centers, which can include such activities as high yoga, meditation, spa treatment, and more. I've run through it. I've got my 10 minutes, I think, and that's great. Thank you very much.
All right. Thank you very much, Kelly Glass. Can I hear a round of applause for Mr. Kelly Glass, please? Right. So St. Vincent being the leader within the OECS region in terms of the development of an integrated cannabis value chain, where from seed to actual sale is actually taking place. So there is a lot of lessons to be learned from the St. Vincent model. Also, we would like to thank Kelly Glass for being such a risk taker and entrepreneur to really support the development of this industry in terms of being the risk taker that he actually is in terms of setting up such a business venture. So thank you very much, Kelly. And with the interest of time, we would like to move directly into our next speaker, which is a colleague of mine at the University of the West Indies Mona campus, and Dr. Gadamawi Naif, and he will be presenting on cannabis and the agriculture industry. Welcome, Dr. Naif.
I give thanks, Mash, and give thanks to the team of our friends. I'm start explain those advocates for ganja that put for time.
I'm not really hearing it clearly. Greetings, Naif. We are unable to hear.
You hear now?
I'm hearing you clearly, but we are unable to hear the recording.
You know about the music. Well, I'm going to start by the real strategic advantage in this era of what is called cannabis and medical marijuana. However, there might be a need to rethink or we adopt some of these definitions, just ensure that we are really creating an advantage in the broader space. There are a couple of things we need to consider when we think about the cannabis and marijuana industry and the ganja in general. The Caribbean becoming one of the four logistic space, which means there are increasing movement of persons and goods and services across the region, which means that applications of legal trade and illegal trade as well. Climate change. How is that the ganja, the cannabis plant have a role in climate change, not just in terms of necessitating areas where there is deforestation, but in terms of the products that are made from the ganja and their impact in terms of reducing things like skin cancer and other related illnesses that will be worsened by climate change, including olfactory illnesses. The Caribbean and the SDGs. We think about what the SDGs are in terms of reducing hunger, reducing poverty, improving health, a number of other factors. We can see where the ganja plant will have a significant role to play, and general health, wealth, and food security. Health, wealth, and food security. So we'll give more details. Let me just start by saying, using a quote from Haile Selassie, states that only when a country and people that become self-sufficient, yes, by the agriculture can look forward with confidence in the future. Agriculture is not only chief among those fundamental and ancient tasks which have been essential to society, but also ranks first among the prerequisites to industrial and other forms of development. Yes? And only when a solid agriculture base has been made for a country's commercial and industrial growth can ensure the attainment of the ultimate goal of our program, which is need a high standard for our people. That's a very important statement because ganja is not just about the medical industry, but ganja is primarily anchored in the agriculture sector. And when we speak about the Caribbean become logistics space, here's what Jamaica has planned in terms of their own logistics space. Community ports, dry dock, airport base, port base, economic zones, of industry, which means a lot of opportunities will emerge for persons who are involved in the ganja industry, whether it's for traditional medicine or for contemporary medical practices. When we speak about the SDGs, crucial. We need to see how the production marijuana, ganja, cannabis, we want to call it. This can support all the efforts towards sustainable development and the SDGs. I'm arguing though that the medical marijuana industry is a necessary, not a sufficient condition, and will lead to some outcome because countries in America will continue to have their restrictions of the plant in terms of foreigners into their market. So when you think about what we're doing, at best, medical marijuana is most like an import substitution model. Yes, we need to develop our own parallel industry focusing on wellness and therapeutics. The nucleus is about 240 billion US dollars, and ganja have a lot of nutraceutical properties. There's a need for a real approach to truly benefit while reducing negative external. I'm going to show you what the negative externals are. And we must look at models. What are the business models? I'm sure it's called social entrepreneurship. Through social enterprise, I think creates a win-win scenario for all players in the industry. And the SD, no poverty, hunger, good health, good quality education, gender equality, clean water, sanitation, energy. All 15 goals of SDGs, we can see the connection to the medical industry, the cannabis industry, as an aid and as a vehicle to help us to attain these things. But it requires what is called an integrated approach, which takes into component 3 key elements: the psycho and social and political elements, biodiversity elements, and economic elements. And that's what the SDGs are breaking out into. If you examine the industry in terms of economic impact on the legal condition, there's high cost of fighting the trade. There's significant loss of enterprise opportunities, loss of revenue to the state because the state will get taxes from export of ganja illegally, and high operations costs, and limit the value chain, and high import for certain things like seeds and fertilizer. Once it's legalized, the landscape becomes different because there's an increased multiplier effect from the diverse industry. There's reduced dependency on while supporting alternative tourism models like wellness tourism. And importantly, we need to recognize once you start to push the medical marijuana industry, it is not replace the medical industry. What it's doing is upload diversification and more opportunities to engage in further activities related to ganja production, whether it be seed breeding, whether it be plant raising, whether it be inputs, etc. So it's a focusing on both as against one generates more opportunities for us in the industry. There'll be an inflow of another revenue, greater distribution of wealth, different classes within the region. When we examine the psychosocial impact, this is phenomenal. Because under the legal regime, you sense of a kind of negative mindset created amongst people involved in lower self-esteem. There's a continual absence of fathers from home because under the legal regime, fathers leave the families and spend months in the hills away from their families. Lack of trust between the state and the citizenry. And of course, there's a stigmatization of communities that are known for being ganja producers. I know that before ganja was decriminalized in St. Vincent, when you think about Rosemont and Rascalos, who was behind the whole industry in St. Vincent, I thought it was seen as an illegal act, but I know somebody was celebrated in St. Vincent because of the work done. When it has become legal, you can reallocate resources that were used to fight against farmers to support youth forms of programs. Yes, you have improved relationship between the state and the citizenry as we are seeing taking place in St. Vincent. That's not happening as fast as it should. Sense of result. Biodiversity is a big component. Under the legal regime, we shall go in the mountains to plant, destroy a lot of flora, and of course fauna, which supports a lot of other elements within our own ecosystem. Habitat destruction, pollution of water and watersheds, use of fertilizers and pesticides for our waterways. Of course, a loss of genetic and genome resources. Again, under the legal system, you have the preservation of the habitats, restoration of mined out areas. If you go to a country like Guyana, if you're not thinking about just medical marijuana, but about the male species of the plant, the component that can support the replanting of trees in mined out areas in Guyana, the rehabilitation of the soil, and support for nature the wellness sector. Just if you're just going to be reminded by a statement made, if we're going to be reminded by Jack Heron, very popular book, There's No Clothes. He argues that if all fuels and their derivatives, as well as the deforestation of trees for paper and agriculture are from use in order to save it and reverse the greenhouse effect, then there's only one known renewable natural resource over for paper, textile, and meet all the world's transportation, social energy needs. Reduce pollution, clean the soil and clean the atmosphere. And that is the cannabis hemp/the ganja plant. So, was it clear that the ganja is not about pharmaceutical products? Medicine is a holistic term. It's not about a tablet. It incorporates so many other things, including the simple thing as a food. So it's about food, water, and health security. We know the research has shown that the cannabis plant is good for all kinds of illnesses. Asthma, glaucoma, nausea, Parkinson's, multiple sclerosis, dystrophy, and tumors. The seed itself, the hemp seed, the composition of the seed is unique in the vegetable kingdom, where 65% of the hemp seed protein content is in the edestine form. Yes, means it's in the form in the human plasma. The climate change, we know again, 50 times in renewable biomass survival on the planet, including corn starch, the ganja plant, the cannabis plant.
Excuse me, Knife, 1 more minute.
Yeah. Relates to uses of the ganja plant, biomass energy, food, oils and protein, building material, housing material, ship sails, oils and fabrics. What we're saying is that the ganja plant, while not being a panacea, is a very important element that stimulates growth and the region. The medical, a very important element. One element. Look at the Caribbean spaces over the mainland. We have mainland countries like Belize and Guyana who can plant industrial component. Islands like Jamaica, Dominica, St. Vincent, Montserrat could plant the female plant that have the THC levels. And other islands like Barbados, Anguilla, Cayman could focus on the plant, the seed. So I'm saying we do not need some game. We can create a win-win scenario. We can look at a model, create economic value, social value, environmental, and all. But to be clear as to what model, who we're creating value for, how we're creating value, what are our advantages, how we differentiate ourselves, how do we make money. But to lay this, we need to establish the frame, a very serious framework that speaks to governance, enterprise development, research and incubator support, policy development, and how do we establish partnerships. So in conclusion, medical marijuana is necessarily sufficient. The region has a strategic advantage in both male and female medical, recreational, and industrial use of the plant, and it creates a basis to push integrated agricultural practices to reduce regional import bill, not only of food, but also. So give thanks.
All right, thank you, Dr. Gadamari, for such an insightful presentation looking at the association, how important the agriculture sector is in the promulgation and the development of a sustainable cannabis industry. And we have seen in the region that St. Vincent is one of the few countries that have developed the medical cannabis authority within the Minister of Agriculture. So that sets a different signal. We have seen other countries where it's in the Ministry of Investment, Commerce, it's in the Ministry of Health. What I would also like to say here is research has definitely showed that first world countries have relaxed cannabis legislation, particularly because of medical persuasion. In the developing world, it has been slightly different, where economic stimulation and restorative justice has been the driving force for relaxing cannabis legislation. However, because of the international conventions that we are faced with, we are left to develop medical cannabis industries that does not necessarily fit our socio-economic and cultural norms within the regional demographics. And the word ganja is more than just a plant. It's a connotation that signifies a culture of a people. So I know every Caribbean country is focused on developing an internationally regulated cannabis market, but the development of the local industries is going to bring about that sustainability and integration of the artisanal cultural heritage that is currently being leveraged because of international investment and so forth. So to understand how important the policy framework is in bringing the cannabis value chain into a sustainable and economic viable industry, I would like to introduce our next speaker, Mr. Mapp, who will be presenting on the Cannabis Industry Act coming out of St. Vincent and the Grenadines. I know Mr. Mapp was having some technical difficulties. I'm not sure if he was able to join us back. I'm not currently seeing him within this particular platform. Can anybody provide me some more insight into Mr. Mapp? If not, I am willing to open the floor to any questions that we may be able to entertain from our two speakers that have gone so far.
Any questions in our in-house audience? St. Kitts Nevis.
Yes, good afternoon. My question is going to be directed at the first presenter. Since the implementation of the legalization, the industry in St. Vincent, what have the profits looked like? I don't think I was able to see that. What has been the income generated, the employment generated, and the profits?
Thank you. The profits are, it's quite a sad story, to be honest. The profits are negligible. We're running at a huge deficit. It's not an industry, certainly for export to the EU and that type of thing. The testing and so forth and approvals and becoming a GACP approved grow facility, which we have greenhouses, shade houses, and also we grow outdoors. We have a trimming and dehumidification or drying center, and then we have our extraction facility. 3 different facilities, all have to be, and our extraction facility is SVG GMP approved, and we're looking to get EU GMP approved. They're crazy numbers to get the approvals and so forth. So yes, there isn't any profit. I'll be very honest. We're in it way over 2 years. And we've stubbed our toe a few times, but we're certainly running at a huge deficit. So I'm really hopeful for the industry. I would really hope that regionally we can start to export. We're getting inquiries certainly on CBD products from OECS countries. I'm not sure if I'm allowed to say which ones they are. But we're looking forward to, the opening in the region, man. It's got to it's almost like the traditional. We should have been almost in the session beforehand, because along with arrowroot and every other ginger, all these other things, the cannabis root is fantastic for cold. I mean, everybody that's listening knows the benefits of it. And certainly for the PST, you know, the medical side of it, the depression side of it, it's a fantastic product. It's just getting through. I mean, we'll never get to America. Canada's got a glut. You know, so let's forget about profit. There is none. Employment, we go up to 100 people again, so with lots of wages to pay, but we're getting a really good skill set of people with they have very good eyes now, spotting, you know, we absolutely don't want any males. We get feminized seeds, we clone. A male in our neighborhood can be a disaster, turning females, you know, into seed. One seed in our flowers turns it into we create oil from that. It goes from grade A flower to grade C or D or E very quickly, you know. Anything on the lower part of the plant, which is near the ground, which, you know, may have had rain or dirt bounce up on it, this is all turned into oil, into tinctures, into vape, well, not vapes particularly, but into topicals and that sort of thing. So we actually have 23 different products. We have lots of product. We have very, very, very good products if you go on the website. And we're very proud of them, you know, not just the product inside it, but the way it's been. To get into a vape, for example, it's childproof. We don't do gummy bears. We do a cannabis leaf. We think it's, you know, we don't want, you know, everything to be, I don't know, first world compliant and that kind of thing. I'm filling in time for Terrell, Mr. Mapp. But we have, it's been a good supplier of employment skill sets, but we're not seeing any benefits from it financially yet. Thank you.
Yes, and thank you very much for that question. It's a very important one, because even within the Jamaica context, where the industry is slightly older, where it's going on 8 years now, it's been very difficult to estimate the economic value of the regulated market, because the values come in based on local trade, international trade, regional trade has not been forthcoming. And to understand the level of investment, the level of competence, the level of operations that is needed to create a sustainable, vertically integrated cannabis value chain, it's going to take a particular length of time to appreciate the linkages between the forward and backward linkages, and also the support agencies that are going to support the value chain.
I think that speaks to a bigger, and that was the same answer we had in Jamaica. When you're embark in move industry forward, you have to do some research in terms and developing what is a clear business model. And looking at the business, you don't look at what your market segments are, all those things have been an estimate of what the potential market will. So that is that. Many of us have approached this industry not as an industry. We're thinking about it. I think regulations and the products more than the economy of the business it should be done. You know, so we put car fast. We can still go and look at those things. But for one of the lessons that we have learned, especially in Jamaica, is that we need to develop very clear, robust business models. What are we truly offering? What is the value proposition that we're really offering? You know, where's our real market? Is it the local market? Is it an international market? Where's the market? Those things weren't done in a meaningful. Therefore, you have even made an initial the estimated market size would have been and what the estimated revenue would have been as well. So we really need to approach it as a business. Yeah, we need to approach it as a business, how you approach any other business area. And we did not do that. I think Jamaica, making the different jurisdictions,
Sure. Thank you, Dr. Knight, for that insight. And yes, and there are lessons to learn where we have seen where the focus has been on inversion and diversion, particularly of the final product, which is the cannabis flower. But the Caribbean region in particular is no stranger to agricultural value chains. We have partaken in agricultural value chains. We have seen the contribution based on what bananas have done within the OECS, and we have seen what the decimation of the banana industry also brought to this region. And based on data coming out of St. Vincent, we have also seen that in terms of the number of seizures within the unregulated market, we have seen where the contribution economically that cannabis may proceed to the local sector may have outweighed the contribution that bananas would have done in its heyday. So if the Caribbean region is to benefit holistically from the development of a cannabis industry, the development of our artisanal cultural leverage must be taken into consideration, where geographical indicators, breeders' rights, and those things must come into play to bring about that sustainable development and approach. So we have with us Mr. Terrell Knapp from the Medical Cannabis Unit from St. Vincent, and he will be presenting on the Cannabis Industry Act coming out of St. Vincent. Help me welcome Mr. Knapp.
Greetings, Dr. Emmanuel, and a pleasant good afternoon to everyone. My apologies for the little technical issue that I just experienced, as my computer worked really well since this morning and just happened to face some difficulties just before my presentation. Is everybody seeing my presentation, just to be clear, Dr. Emmanuel?
Yes. Yeah. And we are hearing you clear.
Thank you. In 2017, St. Vincent and the Grenadines set about to establish a well-regulated, clearly defined, export-oriented medicinal cannabis industry that is internationally respected and incorporates traditional cultivators of cannabis. Consultations were held across SPG, including stakeholders such as the Christian community, our Rastafari brothers and sisters, traditional cultivators, the police, medical practitioners, and investors. These consultations gave birth to the Medicinal Cannabis Industry Bill, which, after being refined in Select Committee, received full approval from our Parliament on December 11, 2018. The bill, which is now Act, in a nutshell, provides for the establishment of a medicinal cannabis industry that regulates cultivation, production, supply, possession, and use of cannabis for medicinal purposes. That is for persons with qualifying medical condition. And the Act names over 20 medical conditions. The Act also sets out the governance framework of the Medicinal Cannabis Authority as a regulator and the operational mechanism under a Chief Operating Officer, Dr. Gerald Thompson, to oversee the day-to-day operations of the authority and regulating the industry. This Act was bolstered by the gazetting of several pieces of regulations, including the Medicinal Cannabis Licensing Regulation, which detail the application process and the requirements for obtaining a license, patient access to medicinal cannabis regulations, which was gazetted in 2020, and outline the manner in which medical practitioners may be authorized to participate in the industry, how a pharmacy may be licensed, and within the framework, within the realm of pharmacies, we have dispensary pharmacies like those that sell not just medicinal cannabis, but traditional pharmaceuticals. We have consumption lounges that Mr. John pointed out, Mr. Kelly Glass, pointed out. And we also have wellness centers. The law, the regulations provide for wellness centers, which may be set up at a hotel or spa. The law patient access regulations also provide the framework, the general framework by which patients may access medicinal cannabis. Then we had the gazetting of the standard and compliance regulation, which essentially encourage quality at the level of cultivation, where the focus now is on GACP, good agriculture collection practice. Quality at the level of manufacturing, good GMP, good manufacturing practice. And the whole issue of quality assessment, analytical testing, and having an analytical testing facility, laboratory, so to speak, to test medicinal products. These legislation provided a solid foundation upon which SVG's medicinal cannabis industry has been able to register several achievements. Let's start with banking. Our Bank of SVG, Bank of St. Vincent and Grenadines, through a robust framework with Toronto Dominion Bank in Canada, has facilitated the flow of funds to our cannabis industry from across the globe. In addition, licensees can establish medicinal cannabis bank account. And by licensees, I mean investors, traditional cultivators, and local cultivators. Cultivation. Sites have been set up across the island with significant research done on strain selection and propagation techniques. Traditional and local cultivators are working with investor entities and are being included in the industry. Several licensees have actually achieved EU GACP, Good Agriculture and Collection Practice, which is a vital requirement to export cannabis flower to the EU. Manufacturing. One company has started extraction, while several others are in the setup phase. This company has achieved GMP, Good Manufacturing Practice, pursuant to the requirements of our Bureau of Standards in St. Vincent and Grenadines. And that company has rolled out a line of refined products, including vapes, tinctures, capsules, and lotions. Analytical testing. A state-of-the-art analytical testing facility has been established in St. Vincent and Grenadines since 2021, with the capacity to undertake testing in relation to potency, bacterial load, pesticide, heavy metal, and residual solvent. This facility is a central pillar to our regional cooperation efforts, as its services are offered to the entire region. Retail. The MCA has trained over 100 medical practitioners in prescribing and dispensing medicinal cannabis. Dozens have been authorized to do so. 5 pharmacies and 3 consumption lounges now provide access to medicinal cannabis. And hundreds of patients, including locals and visitors, have actually accessed medicinal cannabis here in St. Vincent and have provided quite favorable reviews, which the MCA is currently studying. Cannabis flower has been shipped from SVG to Germany. Taken together, these achievements have resulted in over $30 million in private sector investment in our cannabis industry, creating employment for in excess of 120 persons, many of whom are young males, young females, and traditional cultivators, in many cases as master growers, lead growers on the farms. which overall, this investment overall shows resilience, considering the body blows inflicted on the industry by the COVID-19 pandemic, Lassa eruption, Hurricane Elsa, and now the Russia-Ukraine crisis, which has caused prices and essentially cost of production to skyrocket. In addition, our industry has attracted significant regional and international attention. We have welcomed the likes of Kevin Garnett, former NBA player, star Kevin Garnett, Busy Signal, popular Jamaican reggae and dancer artist, ministers with responsibility for cannabis from Jamaica and St. Lucia, and delegations from practically every Caribbean island who have toured many of our facilities and have had the opportunity to have a first-hand experience of the medicinal cannabis industry. While notwithstanding these achievements that I have laid out, much work remains, a significant amount of work remains, particularly as it relates to achieving a steady flow of export and incorporating our traditional cultivators into not just medicinal cannabis production, but into this whole aspect of alternative development, where they participate in other forms of agriculture, given the opportunities that are emerging in our agriculture industry and against the backdrop of food security. SVG remains committed to this work and to regional cooperation, which is critical for advancing this industry. I thank you.
All right. Thank you very much, Mr. Knapp, for such an insightful presentation of the St. Vincent and the Grenadines cannabis industry. I would like the audience to help me congratulate the St. Vincent Medical Authority for such hard work and such great achievements in laying the foundation within the OECS for the development of regulated cannabis. So, moving on, as we know, we started late, so I would like to open the floor for questions currently. And we would like other questions to be directed to one of our panelists and try to make your questions very short and clear, please. Thank you.
Good afternoon, Dr. Emmanuel. I have a question for Mr. Mapp. Has there been prioritization of the Rastafari groups and traditional growers in the development of the industry? And the second question is, of the 150 cultivation licenses, how many of those were granted to foreign entities? And I also want him to give us a little more detail on the exportation of flowers to Germany. How did that come about, and what is the extent, the economic extent of that arrangement?
All right, thank you very much. Mr. Knapp?
Thank you. Of the over 150 licenses granted, majority, I think, is close to 100 are actually traditional cultivators. We have created a special space for traditional cultivators in that they only have to pay $100 application fee. And once they have license, lands and the requisite documentation, they are able to obtain a license. About 18 companies have been, investor companies have been approved for cannabis licenses, but COVID has hit us so hard that we only have a few investor companies. The export of cannabis to Germany, exportation in general. Let us start, I am an economist, but let us start from the social history point of view. To have been able to export cannabis to an EU country was I think historic will be an understatement. It was really a huge achievement by the country. And to do so, an entity, a licensee, has to start a conversation with a buyer in the respective country, let's say Germany. And there has to be conversation between the authorities. So like how the MC is the competent authority in St. Vincent, there is also a competent authority in Germany that regulates the cannabis industry there. That competent authority in Germany will issue an import authorization to the licensee to be able to ship the cannabis to Germany. And we will issue on our side, BMC, having reviewed all the documents, an export authorization. But as I said, critical to the exportation is having EU GACP. So several of our companies have gone through rigorous assessment by the MCA and oversee auditors, so to speak, and have completed the whole certification process and have achieved EU GACP. So that's necessary for having cannabis flowers exported to the EU.
Right, thank you very much for that question. And yes, it's a very convoluted approach in terms of global trade within cannabis currently. And Jamaica, for example, have exported to 10 different countries. They have exported currently more than 5 metric tons of biomass. And I understand that the level of operations and investment that is needed to secure participation within the international market does come at an astronomical cost. So at the onus, currently it's on the development of public-private partnerships to enable participants across the board to be able to get access to these international markets. However, with that said, the local commerce within the local markets and the regional markets seems a much shorter reach or a low-hanging fruit, where in the region, particularly within the OECS, where there is a common framework that could be developed where resource sharing, as mentioned by like Mr. Knapp, where every country would not have to invest in the level of operational infrastructure that would be necessary to promulgate the development of such this sector, but to analyze the resource sharing and needs based on the various markets and contributions. For example, St. Vincent and Dominica and these places have water. So the cost of production, we need to understand the economics and understanding the cost of production and quality assurance, public health and safety, and certification and standardization in order for us to access some of these international markets. So point well taken. So we'd like to open up the floor for the next question.
Thank you, Dr. Emmanuel. We have another question here in St. Kitts.
Greetings. Two questions, really. One of us concerned. When CARICOM went through the islands a few years back, there were some recommendations. And CARICOM did recommend that we approach this whole cannabis industry as a region. And of course, we would all see the various benefits, economies of scale, and all kind of things that would come along with it. How do we see that approach now? Or is it that individual islands are just going about doing their own thing? Secondly, you would have mentioned that the medical practitioners would have been trained in some numbers. And I have an issue in that our traditional healers and medical practitioners are very limited in terms of what they can do. If it is that you had to train the medical practitioners to deal with the cannabis industry, how come, I would like to recommend then that our traditional healers and practitioners, if all they need is just that training, because obviously they have the knowledge, maybe more than these medical doctors, then how many of these were were trained? How many of your local or traditional farmers are able to prescribe the cannabis within your country?
All right, thank you very much for this question. Is this question directed at Mr. Knapp?
Yes, give thanks.
All right, sure.
Thank you for your question. Pursuant to the Medicinal Cannabis Industry Act, as I said, we had consultations and we had a wide stakeholder group, including medical practitioners and traditional cultivators, members from the Rastafarian movement. Only medical doctors can prescribe at present. So most of our medical training with respect to prescribing and dispensing have been focused on medical practitioners. But we have had numerous training sessions for traditional cultivators and the Rastafarian community. And the important issue of quality, good agriculture and collection practice, hygiene standards, track and trace. And those conversations have moved. And I know my CEO is listening, who is a physician. They have moved and they have incorporated the whole aspect of the medical side of cannabis, which is very exciting too. And so we have had those conversations with traditional cultivators, and we tend to do it in the whole scheme of the public. I know my CEO goes on radio and have those conversations about the medical benefits of cannabis. So it is in that light that we tend to bring on our traditional cultivators and the Rastafarian community in the whole vertical integration of cannabis. I hope that answers your question.
All right, thank you, Mr. Knapp. If I may also add to this discussion in terms of if we look at the previous panel where the traditional herbal industry that has existed and has contributed to health and wellness in the region in such a significant way. We have not also, because of the medical connotation that is associated with the medical cannabis industry, it seems to limit the approach, and particularly the medical practitioners who presently prescribe cannabis, because they are actually coming from a pharmaceutical background. So seeing that cannabis is a plant-derived extract that pretty much brings about different formulations, and as we know, the wide myriad of phytochemical compounds that exist within the cannabis plant, and how do we titrate, how do we formulate, how do we dispense, and how do we consume these actual products presents a current challenge based on the limitations that what exists within the pharmaceutical councils of the Caribbean and the ministries of health. So because they have an autonomy on the approval and regulation of these products, it still limits the traditional cultivators' approach to cultivation, processing, formulating, and actually dispensing cannabis. So it brings us back to the previous panel that pretty much looks at the holistic healing of our plant-based medicines. And I am sure Dr. Naif can also comment on this also.
I think it goes back to what was our thing about the industry. Yes, and what real value proposition that we're actually offering. But that is clear. You'd have thought about a framework that would have supported it, including our traditional planters and our traditionals. Because gan, the traditional name for ganja, but we also use the term herb to represent all as well. And so if you are thinking about ganja as medicine, which is more than pharmaceutical, it means you'd have to take into consideration all the other elements the British actually asked about. I think we might be useful for us to look at a place like the Indian Board of Medicine and see what they have done in terms of how they it about practices as part of their scholarship at university certification at universities, as and they even persons with traditional medical herbal practice as persons who would have to take courses as well. But I don't think there was a genuine interest in incorporating herbal traditional ganja farmers, new in. Yes, if you ever look at a place like Jamaica, which was one of the first places in the Caribbean, we see it as would engage with investors. Our primary targets for investment would have been foreign direct. So we're using the same long-time approach, which has not worked. But we have an opportunity now to rethink the model.
All
Use a
right.
different approach
All right.
to agriculture generally.
All right, thank you, Dr. Nye, for that response. I have a few questions coming from our Facebook audience also. So question coming from Charles Pemberton. How do we marry the legalization of traditional medicine and the development of the Caribbean cannabis industry? So if I may just comment on that question, right? The approach to regulated cannabis must take a holistic approach. We have not focused on the research, right? And I understand research may be expensive, but understanding the attitudes and consumption patterns and our cultivation mechanisms, our style, to understand efficiency, genetics, to understand the value chain from an economically sustainable point of view is going to be critical of how we engage all our public and private partnerships. And we have yet to see public-private partnerships to be generated from the cannabis industry regionally that is going to support and develop particularly the support linkages. For example, the cannabis industry, particularly the medical industry, has focused traditionally or focused on regulating the flower, right? But agricultural industries such as cannabis, the most important agricultural input is the actual genetics, the seeds. We are currently seeing people in the OECS region where the National Narcotics Board of Control presented in their last report that they have seen a significant increase in regional, in terms of Caribbean people trying to import cannabis seeds from American seed banks. And these seeds were bred within a temperate jurisdiction. So the performance and stability within an equatorial climate is going to be very much different. And my research has shown that you may be putting way too much inputs to grow particular cultivars than exploiting the economics of growing more suitable cultivars. And well, may we proceed to the next question? Is there anybody within the panel who would like to comment on this particular point? Now, how do we marry the legalization of traditional medicine with the development of the Caribbean industry? Mr. Kelly Glass?
Nutraceuticals. It's that era of nutraceuticals and functional food is a big opportunity, not just for medical ganja, but for all Caribbean herbs. Big area, 240 billion US will be the size of that. But you might find that we're not using our the lens. We are using a copy lens. So we want to copy what other persons have done in other places, rather than looking at what is our own strategic advantage and how this can support our own local development. We look at the many uses that the country.
So, yeah, excuse me, Dr. Naib, due to the interest of time, we're supposed to cut off at 1 p.m. and this is Jamaica time. So it's currently 12:59, right? So I will take one question from the St. Kitts audience and then I will ask my panelists to just wrap up and give their recommendations and I will conclude thereafter. Thank you.
Yes, thank you. My name is Talionu. I'll be very succinct. I have a question for Mr. Mapp. With regards to what Mr. Kelly Glass had mentioned in terms of the market and CBD and it being what is really being adopted in the tourism sector, do you have like a different regulatory pathway to distinguish between CBD and THC? That's one. The second one, really quickly, is there a program in place to support traditional cultivars? Because they tend to be at a disadvantage when it comes to financing, as opposed to foreign direct investment, or is it that you encourage the foreign direct investors to partner? So is there a specific program to facilitate partnerships in order to get adoption? And last but not least, this question has to do with R&D, just based on what has been discussed. In terms of supporting, I would say, the medical sector, is there any R&D programs to facilitate having the practitioners kind of create like maybe what you call almost like a pharmacopedia, but like a dosing regime, because that seems to be something that is off. Thank you.
All right, thank you. Mr. Mapp.
Thank you very much for your question. Yes, we have rolled out a regime for regulating CBD, kind of separately from THC products, having studied the impacts of CBD products. So persons can go to a pharmacy area that is distributing CBD products and access CBD products without a prescription. But in the case of THC, they do need a prescription. With respect to dosage, the Medicinal Cannabis Authority has a technical team led by Dr. Thompson, who is a physician by training. And we also have an advisory council. And we have studied the patient access side of medicinal cannabis and have actually created a document on dosage, in addition to several other documents and administration of medicinal cannabis. With respect to traditional cultivators, investors, and the whole support for traditional cultivators in ensuring that they have a smooth transition into the industry, I must say, when we started off, it was quite exciting time. We had over 60 big investor entities who came and explained plans, outline plans to set up shop and to work with traditional cultivators. So many of our traditional cultivators had partners with investors because we recognize that the investors, significant capital is required to roll out this industry. But in addition to that, investors are the ones who have built those links with the markets in Germany, in Europe. They have been the ones who have built those links. But after COVID and Lassa Free, there was the body blows that were inflicted on the industry, because many of our investors, those who even had paid for the license, to be unable to go forward to set up shop. And so that relationship between investors and traditional cultivators have sort of not gone as smooth as we had envisaged. We, the MC and the government, the Ministry of Agriculture, from the start, from the get-go, recognize the need, the importance of supporting our traditional cultivators because they are very close to us, given their struggles. And we roll out numerous training programs, good agricultural collection practices. And that was halted by COVID and loss of free. And now that things are recovering, we are starting back that process. In fact, I wish to announce that come this April 27th, we will be having a big training session with traditional cultivators. And I must announce that Dr. Emmanuel, who is here, would be one of the leading presenters at that session. So the traditional cultivators are there to us, investors are there to us, medical practitioners are there to us, patients are there to us. Every stakeholder in the industry is there to us, and we are working assiduously as a country in ensuring that they receive the benefits of this industry.
All right, thank you very much for that insight, Mr. Nab. I know I said this was the last question, but it will be only courtesy and respect to invite Mr. Garfield Alexander, who is the chairman of the St. Kitts Cannabis Licensing Authority, to pose his question and to give final comments before we actually wrap up. So I invite Dr. Garfield Alexander.
Hi, good morning. Good afternoon, sorry. That's when you didn't have breakfast. Marshall, I think it would be remiss of me if I didn't invite you to speak on the Caribbean land-raised sativa and the importance of that and some of the research you've done on that being the juggernaut that you are in our industry. And I'll ask Mr. Knife, we spoke earlier about decolonizing the industry, decolonizing a lot of the other aspects. I want you to speak a little bit on the decolonization of economics, because a lot of the economics that we've practiced and we've been taught, and the pedagogy of economics has been very extractive. And if you could speak for a little while on that. I had another question for Mr. Mapp, but I don't remember it at the moment.
All right, thank you very much, Doc. I will ask Dr. Knife to actually go first.
But you see, grounded scholarship is important, and the burden is correct. We need to use an economic model that reflects and fits our own approach. So rather than use a foreign direct investment strategy based on industrialization by invitation, why are we not using a diaspora direct investment strategy if we think that we do have enough local producers in the capital? And I've always said that every Caribbean country have a but no diaspora direct investment policy. And if you get retention of profits into your country, the person who are the investors must have an interest in retaining those profits within the country. And a non-Caribbean person export generated locally, while a direct member might want to money within the local from which he actually originates. Who agree? Approach has to be, the thinking has to be, and the models developed must reflect own indigenous economic thinking and analysis.
All right, thank you very much, Dr. Knife. So in terms of cannabis germplasm for the Caribbean, I could give a whole lecture on this, right? However, I will try to be as practical and prudent as I can in explaining the actual benefits and potential that we have. So currently, we are losing our indigenous landrace cultivars as we speak, because of the global market and the perception and the modern palate that is associated with actually consuming cannabis today. However, when I have surveyed and traveled the length and breadth of the Caribbean, looking at cultivation styles, looking at the traditional farmers, looking at the challenges they face, particularly in regards to their to their genetics, we have seen a lot of diseases such as tobacco mosaic virus, cucumber mosaic virus. There is also the hops latent viridae. So if you are to grow these particular seeds or clones, you will never get the sort of commercial biomass that would allow that economic sustainability and economic potential from actually cultivating cannabis within this equatorial region. So just to think in terms of the practicality of the farmers, right? A traditional farmer in terms of St. Vincent, St. Kitts, St. Lucia, Dominica, 99 to 100% of the times they present you cannabis flower, they have seeds in there. And we know that once a cannabis plant is pollinated, the psychoactive component or the medical value tends to be decreased by more than 50% because the plant is no longer producing those trichome glands. It is in reproductive mode. So the energy and focus is on development of the seeds. So think of it, 99% he presents your herb, his herb has seeds, and it's not a male that pollinated it because he has the trained eye to be able to see a male. So it's always a hermaphrodite. So imagine hermaphrodites pollinating cannabis plants and you're growing those seeds 3 to 30 years on. It took me 6 years to actually collect a landrace cultivar in the region to find a pure female plant that did not have hermaphroditic traits within the actual genome. So to fast forward, if a traditional farmer now has to grow these seeds, he has to grow 3 times, 5 times the amount of seeds. He has to water them, he has to have land space, he has to have labor, he has to have fertilizer to end up with less than 10% or 20% of these plants will be remained as female plants. So he has to cull the majority of plants. So think of the effort, the labor that's put into that. If now we equip these farmers with like, let's say, clean planting material in the form of feminized seeds, and he plants 100 seeds, it's going to be 100 female plants. It's going to be less water, less labor, less space to engage in better quality flower that would meet the particular aesthetics and organoleptic qualities that the global market demands, right? So understanding our germplasm, doing research, understanding the potential of what we cultivate. Because remember, in our jurisdiction, the aim is we can grow cannabis throughout the year. However, in a temperate country, they have one chance of flowering outdoors. So the aim is to grow the biggest plant possible. But in the Caribbean, we could grow as many cycles as we can. So I know the Caribbean has a reputation. This reputation was built traditionally. However, it does not translate to the global economics of international commerce associated with cannabis, biomass, and cannabis products. So the focus and the development must not necessarily be on inversion and diversion of the final product, but incorporating the value chain in such a way that it takes a sustainable approach from seed to flower to dispensing to actual consumption. And we could only achieve this by understanding the patterns, understanding our greatest resource, which is our human competence. So even the University of the West Indies is challenged in putting together some academic programs that would develop the competence of our participants who are going to be the future of owning this particular cannabis value chain. So I would like to use this opportunity to ask my presenters for a 1-minute wrap-up to present where they see this industry going, particularly for the OECS region. So I would like to start with Mr. Kelly Glass, please.
Thanks a lot, man. Look, I think it's been really interesting for me. I would like to thank, I think the sponsors, the ECCB, and World Bank and so forth that have put this together. I think regional is the answer. I think it's really important that regionally we cooperate. I'm really glad to hear you speak of the feminized plants and getting rid of these hermaphrodites, getting rid of it, because Vinci weed is now becoming much better than it was five years ago. I mean, you'd be clear on that, and it's great that you are helping with the. We have a couple of really good geneticists here as well, who you must meet when you come down. But it's critical that we start with a really good product, good seeds, then you can get good product from there. The cannabis is a bit of a passion for me because I had throat cancer, and the tinctures I was offered all these. Oh gosh, I can't remember what's the drug that America's addicted to, the Midwest. Oxycodines. I was given them by the hundreds, and sorry, no. I'll have oil and tinctures, which really helped me. So I'm converted. Structure, as someone spoke of, and the lack of the looking at the business plan in the beginning, is we're probably guilty of that. But opening the doors regionally is going to be a big help to us, all of us that are involved in it. We have and to speak of co-op farmers, we have traditional co-op farmers that actually grow for us as well, just to know the integration part that Mr. Matt was talking of. It does exist. And I think internal trade is really important. I think lawmakers, it's legislators, it's really important that we open the doors regionally. And I can see it to grow. It's a very challenging industry, and getting exports to the EU is really difficult. So whoever's considering going into the field, go in with open eyes. And if you have any questions about this, please feel free to call me or to Mary Allen, our CEO. She's very very bright and very experienced in the industry now. And just thanks very much. And of course, as you mentioned earlier, if it wasn't for the banana industry being messed up by Dole, Chiquita Bonita, and that type of thing, St. Vincent probably wouldn't be as advanced in the cannabis industry. It's by necessity that we're in that situation. And the support of the government and the Prime Minister and that is, and and Dr. Gerald Thompson and that sort of thing. They've made to keep it going along, but it's a very expensive business, and we really need the government's cooperation and support. Thank you.
Thank you very much, Mr. Kelly Glass. Dr. Gadamawi Knife, closing remarks.
All right, let me say that the lens is important. This is a zero-sum game between medical marijuana, traditional ganja. It's actually a win scenario. A region, we need to look at it that kind of way, the kind of business models that are required, and expose the various and new opportunities that exist for persons to engage at different levels in the industry, from soil to seeds, to post-harvesting, distribution, etc. Let us use the opportunity to know the ganja industry to support integration in other industries, critically the agriculture sector, and importantly, the health and wellness sector, the climate change. Because remember, with climate change and in agriculture, you have potential risk for you have risk for respiratory illnesses. Persons with high blood pressures are at risk as well. That the ganja, along with other herbs in the Caribbean, have solutions to these problems. So let us use opportunity lens, it's our problem lens, a win-win as against a zero-sum, and move the industry forward.
All right, thank you very much for that insight, Dr. Knife. So let's hear from our final panelists, Mr. Terrell Mapp.
Thank you, Dr. Emmanuel. And I want to thank the viewers who stayed with us throughout the entire sessions from 8:30 this morning. I want to thank the ECCB. Actually, the ECCB is the place where I got my first practical training as an economist. I spent 3 months there in 2012 and I learned the art of research under Karen Williams. So I want to thank her, thank the folks at ECCB Civil Welsh for putting on this important event and for seeing medicinal cannabis, despite all its challenges and a slow rollout, as a pillar for economic growth. And I must say, frankly, when I was an economist in the Ministry of Finance and Economic Planning, and I spoke of cannabis as a driver for economic activity for the future, many persons laughed at me. So it is a dream come true to have been given the opportunity to work in the medicinal cannabis industry. And I have learned so much from all the stakeholders in the industry thus far. It is the most challenging venture I have ever undertaken. But despite the challenges, the industry is quite exciting and holds significant opportunities and potential. And so, in rolling out this industry, what is critical, as I said in my last sentence, is for regional cooperation, which my other colleagues said in this panel too, and Mr. Glass spoke about it too explicitly. Regional cooperation can come in many forms so that we could build out a sustainable and modern medicinal cannabis industry. Cooperation in the area of training of medical practitioners. I mean, our St. Vincent and the Grenadines has learned a lot from the Jamaican experience, what they have done well and what they haven't done so well. There is a lot to learn from the St. Vincent experience, because while we have had many achievements, we haven't gotten everything right, because there isn't a blueprint in rolling out this industry. So there's cooperation that can happen with respect to training of medical practitioners to ensure that they understand the very important question that my colleague in the audience asked about dosage. Training for the farmers and the licensees. Our inspectorate at the MC has built a significant capacity with respect to good agriculture and collection practice and good manufacturing practice, and are able to provide a training to any other Caribbean country that is looking for that cooperation in building out that industry. And I must say that GSCP and those things, they aren't overnight activities. Kelly will tell you better than I do. That's a 2-3 year process, and GMP is even more complex. There is cooperation in analytical testing, as the Prime Minister of Sinket said this morning. We have built a state-of-the-art facility in St. Vincent that is offering its services to the entire region. And there is cooperation in building this sustainable model where we can not just focus on GSCP and standards that have been handed down to us from the international community, but we could roll out our own standards within the region. I want to add too that all of our stakeholders are dear to us. My colleague asked about traditional cultivators who are very, very dear to us and the Rastafarian community. And we do not just give training. We have allocated over 100 acres of lands in the North Leeward community, area called Lasham Tapil, which will be distributed to over 49 traditional cultivators, free of cost, just a lease signed by the government, for them to establish their medicinal cannabis farms and to also do other forms of agriculture.
All right. Thank you very much.
Thank you.
Thank you very much, Mr. Knapp, for your closing remarks. And I would just like to close in terms of concluding that an integrated approach in developing domestic cannabis economies within the Caribbean territories, from policy to legal framework to historical and cultural experiences, business, marketing, science, and medical connotations of view will be necessary. So the academic institutions, the public and private sector would need to coordinate to be able to facilitate the research and funding to provide a greater understanding of the backward, forward, and cross linkages across the cannabis value chain to enact policies that will facilitate the sustainable development and sustainable contribution economically to the Caribbean people. In 2018, Dr. Knife and Dr. Horton, an economist, and myself published a paper understanding the Caribbean cannabis economy from a holistic point of view. And I would like to thank the ECCB for allowing such a platform to advance the discourse surrounding cannabis and cannabis policy, cannabis development. And I would also like to thank the governor of the Eastern Caribbean Central Bank, Mr. Timothy Antwine, and his team for putting such an informative discourse today. Thank you very much.
Thank you, Dr. Emmanuel. So before we talk, Dr. Emmanuel and panel 3, thank you very much. And thank you all for having stayed with us, both online and in-house. At this point in time, we invite you all to take out your phone and we ask you to participate in what is a very short survey online. And this is on www.menti.com. Menti is spelled M-E-N-T-I. And so we are asking that you just take out your phone just very quickly. It's a 3-question survey and it's multiple choice, so it's really easy for us to be able to get through. There is a code that you will have to enter to be able to do so once you would have gotten onto menti.com, and the code is 57318482. And I'll repeat it again. So the code is 57318482. And thank you again for your patience and thank you for your participation. So today we truly enjoyed what would have been a wonderfully diverse dialogue with such a wide range in terms of expertise. And we look forward to tomorrow, where we will be hosting our day 2 of the Growth and Resilience Dialogue, the 7th Annual Growth and Resilience Dialogue. And tomorrow we'll be looking at what is more of a virtual expo, where we will be analyzing new technologies in healthcare. So we look forward to your participation again tomorrow. The online viewers, you are reminded that you would have been entered into what is a draft, and one lucky winner, once they are in attendance at the time of that draw, will be awarded with a gift certificate of $1,000 US or 2,700 EC dollars to be able to have what is your free health check at any center in your home country that you so choose. So again, thank you all for participating, and we now invite you to lunch, those of you who are in-house with us. Thank you very kindly. Have a pleasant day.
The 7th Annual Growth and Resilience Dialogue 2023 welcomes you to 2 days of enlightening healthcare discussions and innovative tech ideas and exhibitions.
Register for free via ECCB's website to join companies, specialists, thought leaders, disruptors, and transformers that are passionate about issues that are key to your health and well-care needs and challenges.
The fact of the matter is that almost 8 in 10 deaths in our region are attributed to non-communicable diseases.